And the top risk factor for us to get that is number 1, higher BMI, higher blood sugar. So we're going to see more and more diabetes, right? For China, for example, for the East Asia, again, you're going to see more and more PAD. Again, the risk factor is higher BMI and high LDL. I think this is the challenge that we will face, and these are the risk factors that we will need to focus, all right? And this costs money. And I'm going to discuss about a little bit on the economics from the physician point of view. As far as Southeast Asian population is concerned, we are getting older. When our patients getting older and live longer, they will come with more cardiovascular disease. They will come with more comorbid. As you can see here, whether you're looking at Japan or even Thailand, by the year 2030, 1/4 of Thailand population will be considered as elderly. And we're moving the elderly society faster and faster, all right? For example, if you look at Japan, Japan takes about 26 years to achieve what we call a geriatric society. But Vietnam takes only 20 years to become a geriatric society. So we will, as a physician, we need to move faster and faster. If we are helping in changing healthcare policy, you will need to move faster and faster because this is what you and I will be facing. And more importantly, right, who is going to pay for the healthcare? And usually it's those who are working and those who are paying tax. So this is also another important point. I just want to look at Singapore, for example. All right, back in 2010, which is not that far away, 14 years ago, you actually have 8 young adults to work compared with 1 retired person. But by the time 2050, it's about 1.5% to work to pay for the geriatric patient. All right? And this is what we face in Europe. Right? There's just not enough people to pay tax to actually take care of the healthcare. So this is what we are facing the challenges. I think instead of treating them with dialysis, treating them with angioplasty, we will need to look at what we can do to actually reduce their incidence of diabetes, their incidence of hyperlipidemia, or control the hyperlipidemia, control the diabetes so that they won't get into trouble. All right, it's time to act. So I'm going from the population. There's actually a lot of things that we can do, right? I have quoted you the example of TV advertising. We used to have vending machine in my school that actually sell Coca-Cola, right, in school. But I think that one has been removed. I'm going to quote you 2 examples that healthcare policy does work and have an impact on healthcare outcome. This is New York State. What they have do is they actually ban trans fat, right? You cannot use trans fat to do your burger, to do your hot dog and all that. And after the ban, they actually can see a difference, a reduction in MI and stroke from here to here. So healthcare policy will work, and healthcare policy does translate into outcome. Even simple things like tax in China. As you can see here, the smoking population or number of cigarettes sold in China is actually keep on increasing. Up to 2015, when China government do a tax, increase the tax on tobacco, then you actually start seeing the blue color line dropping. I think these are the things that the healthcare policymaker and us as a physician will need to work hand in hand to actually change the outcome of our patients' population, because I think there's a lot of states being played, a lot of important things that we need to look into. Otherwise, the healthcare cost will just go on and on and on. All right? I think at the patient level that you and I have been working on, I think this is still important. Education, lifestyle changes, and early initiation of therapy definitely will work, and hopefully we can prevent them before they actually develop in the cardiovascular disease, end-stage renal failure, stroke, for example. I think there's a lot of work that we still can do, but don't forget about the healthcare policy. Don't forget at the national level, population level, especially those that you and I coming from Asian country, that we are being modernized, urbanized, that come together with a lot of trouble, diet changes, lifestyle changes. This, please do not forget when you see your patient. With that, I will stop here and I'll pass to the next speaker.
Thank you, Professor Chi Kok Han.
Yes.
Now we would like to warmly welcome Professor Peter Lansford from the Netherlands. Professor will share his point of view on the topic closing the gap, addressing clinical challenges in early cardiovascular management in primary care. Please, Professor.
Yes. Good afternoon, ladies and gentlemen. It's good to see a full audience from different countries in Southeast Asia. The morning program was very interesting, talking about microbiome, talking about AI impact on medical care, and I think I really liked the last presentation to enlighten us what is facing us in terms of cardiovascular disease or non-communicable diseases in the next 10 years, which is not going to be that long. So we need to start to think differently about how to address those issues. And one really important point is we have to switch from treating diseases to preventing health, to preserving health, sorry. It's a different approach, and I think even in our guidelines, even in our recommendations, there is still a lot of emphasis in first finding the ones at very high risk before we start doing something. And to be honest, I think we're too late if we wait for that. We have to start much earlier. So these are my disclosures. What you see here is a peanut and a atorvastatin 80 milligrams. Which one is more dangerous? What do you think? The peanut, yes. Look, anaphylaxis 1 to 2% per year, rhabdomyolysis 0.001% per year. I never hear patients complaining about peanuts. Yeah, but they're complaining about statins, about high-dose intensity statins. And perhaps you can remember the presentation this morning about how we tend to follow the judgment of other people. You know, if you hear a large group claiming something, you feel more and more obliged to share that same opinion. I think there is something going on also in this realm. Now, I don't have to repeat myself, but still, you know, there's going to be much more challenges in the future. And what can we do to reduce, or what are the reasons why we see such a failure in reducing cardiovascular risk? I mean, we've done tremendous steps forward in treating acute diseases. Mortality in the CCU went from 50% to 5%. Tremendous in the last 50 years. But reducing cardiovascular risk, well, worse environment, maybe our treatments are insufficient, although our arsenal is expanding rapidly, but perhaps we could use new and better drugs. Important point is lack of guideline implementation. Although we have an incredible amount of evidence-based medicine about lipid management, if you look at observational registries, how well they're implemented, it's very, very poor. And last but not least, like I said earlier, we start preventive therapies too late. So what we can do is actually not that difficult. These are the three groups where I'm going to talk about. The healthy individuals, the ones with risk factors, and particularly I think we're facing an epidemic of metabolic syndrome, diabetes, and of course, patients at very high risk. What are major concerns from using not only the right statin, but using the right dosage of statins? Many people think, yeah, we don't need high dose. I mean, low dose is already enough, especially in Asian populations. Yeah, in Europe, maybe they need 80, but what we see in Japan, 5 or 10 milligrams already gets people to target. Some doctors think maybe LDL will get too low. Is it normal to have a cholesterol level of 30 or 40? Well, we consider normal to be like 200. And finally, how safe is it to use high-dose, high-intensity statins? I have 4 topics I'd like to address. First, to enlighten you about the relevance and the importance of cholesterol. Then, a very interesting topic, maybe you're familiar with, it's the cholesterol burden. It's a different way to look at the impact of cholesterol on cardiovascular disease. I'll have a case to present and some conclusions. Now, this is where it all started. This is late 1800s, early 1900s. A guy named Nikolai Anichkov, who was a military physician in the Russian army, he did the first experiment to show that in an animal model, he could develop atherosclerosis. And as you can see, it went very, very fast. In 4 months, he was able to establish extensive atherosclerosis by giving a diet, oil, and egg yolks. Now, this was a rabbit model. And some people criticize it and say, yeah, but, rabbits are vegetarians, so yes, maybe it's more easy for them, and we are humans. Well, as humans, we might not be completely vegetarians, but we're omnivorians. We can eat and we can sustain ourselves on vegetables. Vegans and vegetarians are an illustration of that. But we do have a physiology base that allows us to use combined vegetable and animal products. And I think one of the reasons we evolved so rapidly is the fact that we could use animal proteins to really rapidly grow. Now, this is what happened after he wanted to establish, to reduce atherosclerosis. This is a high cholesterol diet for 106 days, and then followed by a chow diet for 785 days. So 2 years of carrots and salads. So it took 2 years to go from a plaque to more or less a diminished amount of lipid-rich core in that plaque. So in very short time you can develop it, and it takes some time to reduce it, but it's not unlikely that you can do that. One of the challenges we face is that we don't know what is normal. When I ask you, in your country, what is considered to be a normal cholesterol? You're from Sri Lanka. What is a normal cholesterol in Sri Lanka, in the population? 200 to 250. If I ask people from Malaysia, I think it will be probably the same. In the Philippines, it's the same. Another question, what is a normal systolic blood pressure in Sri Lanka? 120. And what is a normal blood glucose in Sri Lanka? 100, 150. Now, what is interesting is that why do we consider a blood pressure of 120 normal? Because if it's higher, you get disease, right? So what we do, we try to get it below 120 because that is quite assuredly very difficult to develop carotid atherosclerosis and strokes. Same for glucose. If it's over 100, 115, you develop diabetes and diabetic complications. So if we have a cholesterol of 200 or less, we don't get coronary artery disease, right? No. We see most of the patients who have coronary artery disease have a cholesterol less than 200. So the normal definition we use for blood pressure and glucose is not being used for cholesterol. How do we get from a cholesterol of 200 as normal? Well, very simply, by measuring. We measure a lot of people, and then we get a distribution, and the 50th percentile is what we consider normal. So that's a different approach. Now, it depends how you look at it. You know, this guy doesn't look normal unless you go to a convention of tattoo artists, and everybody will look that way. And that is how we look at cholesterol. Everybody has 200, so that must be the normal. But I would propose that a normal level, a level where it's unlikely to develop atherosclerosis, is much lower. So what you see here is 3 models, or 3 animals. These are humans, these are pigs, and these are sheep. This is total cholesterol level and 3 phases: fetal, breastfeeding, and adult. And if we look at humans, you can see that during the fetal period, cholesterol level, total cholesterol, is between 50 and 70. And then after birth, breastfeeding, total cholesterol level goes up, 150, 170, because you change your diet. High in fat, high in glucose, high in everything, because you're having a baby that has to develop into a human being. When we look at pigs and sheep, we see the same thing. But after breastfeeding, LDL goes, total cholesterol goes back to what it was before breastfeeding. Why? Because the diet goes back to a natural diet, what pigs and sheep eat. You know, pigs and sheep don't go to a McDonald's. They don't go to a supermarket to get all kinds of processed food. Actually, they did experiments where they exposed them to processed food, and what you can see is that their cholesterol went up as well. And that's what you see in humans. Yeah? In humans, after breastfeeding, you get cow's milk because of bottle feeding, and after bottle feeding, you get a Happy Meal. So cholesterol goes up and stays up. And that has really important consequences. A physiological cholesterol level is between 50 and 70. Now, that doesn't mean that we now have to go back to our practices and start throwing everything we got to get to a 50 or 70, but please don't be alerted or fearful of having these kind of levels. That is what we call a physiological level. Now, this is a boy in the US who died, I think, in a car accident, and they did a post-mortem examination, and look what they found. 3-year-old boy. This is the first stage of atherosclerosis. Now, this is not a boy who had familial hypercholesterolemia or some other rare disease. A very normal boy already had atherosclerosis. Maybe he smoked? I don't think so. Hypertension? Very unlikely. Diabetes? Well, in the US, you're not quite sure, but I think that was also quite unlikely. Actually, in the Bogalusa heart study, they examined children that died at a very early age to look at their coronaries. And what they found, half of the 2 to 15-year-olds already have extensive atherosclerosis in the form of fatty streaks. 1 in 12 already have real atheromas. 1 in 12. Realize also that the first sign of having atherosclerosis is a fatal myocardial infarction in 40% of the cases. Now, we can do a lot with statins, but secondary prevention in fatalities is not yet on the list. Yeah? So that means we have to act earlier. Another interesting epidemiological fact, 25% of males, and this is a Caucasian study, have their first event before age 55. Now, very few people are being evaluated for risk before that age. And for women, it's slightly better, but still also quite impressive. And this is some other post-mortem examination, seeing 29-year-old female, 23-year-old male, 19-year-old male, suicide, homicide, extensive atherosclerosis. So, I have some good news and bad news for you. The bad news, you all have atherosclerosis. Your coronaries do have already lesions. The good news, we can do something about it. We can really make sure that we reduce your risk of getting events. Last piece of evidence establishing that low LDL is actually really pivotal in getting very low risk of atherosclerosis. This is the PISA study, where they looked at individuals with no risk factors. No hypertension, no smoking, no diabetes, completely healthy. And then they used non-invasive imaging to look at atherosclerosis in 3 vascular beds: peripheral artery, carotid, and coronary artery. And they found that even without any risk factors, cholesterol really determined if there was the presence of atherosclerosis in 1, 2, or 3 vascular beds. The only group free of atherosclerosis was with an LDL cholesterol below 50 to 60. Now, we always focus a lot on numbers, and the number of cholesterol as average is 200. Targets have shifted downwards to 170, 55, maybe even 40. But I want to introduce a different concept on how to evaluate your risk of developing atherosclerotic complications. And that's the cholesterol burden. You've all heard of pack years with smoking. If you smoke 1 package of cigarette for 1 year, that's considered, every day for 1 year, that's 1 pack year. After 35 pack years, it's not whether you get cancer, but when you get cancer. That concept has now been sort of transformed into evaluating the risk of atherosclerosis. So we calculated that the threshold is roughly 9 grams over a lifetime. So that's 9,000 milligrams over a lifetime. If your cholesterol is around 150, that will take you 60 years. That's what we see in Western populations. If you're a homozygous FH patient with 900, that will take you 10 years, and that's what we observe. And if you have, for genetic reasons, a very low LDL, then it means you could be protected for a longer period. Now, one of the discussions we always have is that people say, why should we use a high dose of statin? Because if I double the dosage, I only get like 6% additional LDL cholesterol lowering. Is that really worth it? Let me illustrate that. Say you start statins at age 50, and your threshold is 9 grams. So at age 50, you already have 7.5 grams left. So you have 7.5 grams, so you got 1.5 grams left. That means if you start with 40 milligrams of atorvastatin, 45% LDL reduction, from 150, you go down to 82 milligram, 82.5, so that's 67.5 milligrams lower. Had you started with 80 milligrams, 50% reduction, that would translate into a 75 milligrams per deciliter lower LDL cholesterol, right? So the difference is only 7.5 milligrams. Doesn't sound like a lot. But for a long period of time, that means you reach that 9 grams at age 67.2, or at age 70. So that means you have almost 3 years extra by simply using 80 versus 40. And if we compare, for instance, 20 versus 80, then the difference is 15 milligrams. And that translates in roughly 3.4 years. Yeah? So, of course, this is not mathematics, but it sort of illustrates the relevance of using a higher dose, high intensity statin to really have a long-term impact. It's not an antibiotic that you take for 2 weeks. No, this is a drug that you take for the rest of your life. That's what I explain to my patients. Now, best to illustrate this with a case. This is Mr. V, 50 years, businessman, a lot of problems at home, a lot of problems with his work, stressful. He had a checkup 6 years ago, and he was still smoking, but he stopped smoking. This was his cholesterol, this was his blood pressure, diet, no exercise, and BMI, right? Now he comes again because he doesn't sleep very well, has headaches, has backaches. He doesn't feel very good. So we did a new evaluation. And this is what we found. Fasting glucose, HbA1c, BMI, blood pressure, everything went down the drain. Everything went worse in those few years. The only thing that went better is that he stopped smoking. So, now we have somebody with a cholesterol level of 250, LDL of 120. Would you be convinced to start treating his LDL cholesterol with a statin? Or would you say, maybe we should do something in your lifestyle, maybe we should do something in your diet to make sure that your lipids are better? Now, one of the things that we should do is to evaluate his risk. And there's many different risk tools, but I just chose, this is the American risk tool. I could have used the European as well, but because of time constraints, I just show you this one. And what we find is that his 10-year risk is 7.5%. His lifetime risk is 46%. Now, what would you do with this number? Would that be a number that convinces you to do something, or a number that would convince you to say, oh, let's take it easy? What would you do in Malaysia? Do something. What would you do? Start statin. And what statin? Yes. One statin. I added some other things. You could do additional investigations, you could lifestyle improvement, or you could start medication. But in Malaysia, we learned already why. You know, the situation in Malaysia is not that good. You start with a statin. Only a statin, ezetimibe, fibrate is not really a discussion, right? I think statin has so much evidence that's quite clear. Now, I didn't do that with this patient. I said, let's do a lifestyle, because he was very reluctant to start with medication. Remember, he didn't use anything. He already stopped smoking, so he said, listen, I'm really going to push myself, go to the gym, have a better diet, and make sure that I'll come back in 2 months and everything will be fine. So what happens, he never comes back. And when he comes back, it's 6 years later. He's now 56. Because he doesn't feel well, and he feels guilty because he didn't come back to me any sooner. And what we find is everything went really down the drain. His glucose, HbA1c, BMI, blood pressure, smoking is still okay, and his lipids went down the drain as well. We did an evaluation, normal ECG, stress test, completely normal. Now we reevaluated his risk, and look, it's 25.2%. And here, lifetime risk went up a little bit to almost 50%. So with this profile and this lipid abnormalities, now I can ask you, but I think it's quite easy to come to the next conclusion. We have to use a statin. And we do, of course, use high-intensity statin. And if your LDL goal is like 75, which is quite normal in a very high-risk patient, you need at least 50% reduction, right? So you need at least 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. Now, the guidelines are sometimes confusing because we have over 70 different lipid management guidelines. So I think it's still quite comfortable to use the major guidelines from the European Society of Cardiology or the American Heart Association. What we need to do is actually three fundamentals. Science explains to us what we could do based on new developments. Guidelines is what we should do. And registries shows us what we did. And these three are really connected. We need the science. And sometimes the science is ahead of what the guidelines dictate. Because in science, we don't have many randomized controlled clinical trials, or we have meta-analysis of these trials. We have new developments that could be life-saving for some of these patients. So we have to make sure that it is not our standard approach, but it's an approach that we could use. Guidelines is a no-brainer. You know, that's the Bible for how to treat patients. That's the minimum what we should do. And registries are so indispensable. How can you evaluate how you treat patients, what the outcomes are? And they can help you to really improve the way you manage those patients. These are the European guidelines, 4 categories of patients: the healthy, the diabetics, the special patients, and the ones with cardiovascular disease. And what I like about the European guidelines is this 3-step approach. Healthy lifestyle is basic for everybody. So there's not even a thought about that. Exercise, diet, smoking. Basic therapy is the first step. And basic therapy simply dictates to go for achievable targets. And then the extra therapy is for the ones that are at very high risk. So, for instance, this is the step 1 approach, where systolic blood pressure has to be below 140 and LDL more than 50% reduction and below 70. Everybody can reach that. You don't need PCSK9 antibodies, you don't need advanced treatment. This is something that is within reach of everybody in this planet. Then for step 2, slightly stringent levels for blood pressure, 130, and more stringent levels for LDL. Now, this is something that could be achievable, but sometimes in stressful economic situations, that might be challenging. Now, what happened with our friendly patient? After I saw him, he didn't come back 2 months later. He came back 2 weeks later, horizontal with the ambulance, because he had suddenly chest pain and he developed a myocardial infarction. So we really lost precious time in waiting too long to actually treat him accordingly. This is the effect of using high-dose, high-intensity statin, where we could see rapid improvement of its lipid levels, and of course, we establish also adequate treatment for the other risk factors. To illustrate, this is a case history similar to our patient here, 69-year-old Japanese male, former smoker, LDL 143, comes in with a myocardial infarction. His LDL cholesterol really responded well to atorvastatin 20 milligram. No changes in the other risk factors. Blood pressure, HbA1c, HDL, and triglycerides stayed the same. And please note, HDL and triglycerides are really optimal. So this case also illustrates that it's really the LDL that is driving this disease. And this is what happened. Using a simple approach of reducing his LDL cholesterol, effects on the plaque, going from 100 cubic millimeters to 83 to 38 cubic millimeters by using an approach to go for an LDL below 70. So there is great potential. We just talked in the previous talk about the Nihon-san study, you know, comparing patients that live in Japan versus Honolulu and San Francisco. And this is the original publication from 1975 and 74 and 75. And you can see the changes in these risk factors from Japanese living in Japan, moving to Honolulu, and moving to California. Now, this is where how we envisioned Asians before. You know, very frail, very thin, hardworking individuals with a very poor diet, or poor diet with a very good diet, but a low-caloric, low-fat diet. And this is how Asians have changed. You know, they have become bigger, larger, and more like Caucasians. So that means that really careful approach that Asians are too fragile to really aggressively treatment doesn't hold true anymore. We have to establish that they become as high risk as we are as Caucasians. Now, another point is that they say, yeah, but atorvastatin 80 milligram is not a good approach. It's too harmful for Asian patients. They don't need as much. This is a nice analysis from Juliana Chan from Hong Kong, who had access to the data of all the atorvastatin trials. These were 6 long-term trials, 52 short-term trials, and these were the Asians in the study that participated and the patients that used atorvastatin. And what they found is that there was not a big difference between the Asians and the Caucasians in terms of side effects, and that the incidence of these muscle-related side effects were actually quite low. Rare treatment-related adverse events, not observed a dose relationship, and the safety profile of 10 versus 80 is similar in Caucasians versus Asians. This is a cluster of high-dose rosuvastatin-associated rhabdomyolysis that they observed in Hong Kong, because I do think there's a difference between atorvastatin and rosuvastatin. So between July 2022 and April 2023, there were 6 cases of rhabdomyolysis when patients were using 40 milligrams of rosuvastatin. So all guidelines dictate that in Asian patients, the maximum dosage should not be more than 20 milligrams. To conclude, LDL or ApoB really initiates and propagates atherosclerosis. And if we want to address that form of complications, we need to initiate treatment much earlier. Normal LDL is between 40 and 60. Cholesterol burden dictates the progression of atherosclerosis, and earlier intervention is superior. Now, health is not a noun. Health is a verb. That means you have to do something. Medication does the heavy lifting, but you have to make sure you use the medication, and it's also really relevant to do lifestyle intervention. You have to stop smoking. You have to make more attention for a healthy diet, and please do also exercise. Exercise is essential not only for lifespan, but for health span. We don't want to become 80 or 85 in a wheelchair, blind and no hearing. We want to stay healthy and active. And that means you have to keep your body active, and that means also using a proactive approach. That was my last slide. I hope I was able to illustrate some of the important cornerstones, basic things of cardiovascular risk reduction by using LDL-lowering cholesterol. Thank you very much.
Thank you so much, Professor. What a very interesting presentation.
Thank you. Thank you.
And now we will have a discussion together on the topic navigating roadblocks along the patient journey in cardiovascular care pathway with our chairman, Professor Peter Lansberg from the Netherlands, Professor Abhijat from Thailand, and our panelists will be Professor Chi Kok Han from Malaysia, Dr. Frederick Jain from Philippines, Dr. Tham Tat Yuen from Singapore. Please, doctors and professors, come join the stage.
Thank you. Thank you.
All right, it's wonderful to be here with Peter Lansberg, my great friend. And actually, I think that this is the panel discussion, so we have quite a flexible time. Because actually, from the first two lectures, I think that somebody needs to ask some certain question. Because actually, I myself got several questions, but I will do it last. I'd like to have some questions for Dr. Lansberg and our first speaker, Dr. Han, right? All right, any question? No? Everybody is clear? I think it's not that clear, you know. Because actually, for Professor Han, he mentioned about urbanization. And he explained that by having urbanization, things have changed, especially in the diet. But there is some other factors, of course, like stress, like pollution, like noise, anything. Do you like to mention that too? Because I don't know. Because if you mention about the healthy diet, at this time the healthy diet is more expensive than the processed food already. So it's really difficult to tackle this problem.
Yeah, thanks for the question. I think definitely pollution is definitely something that has been shown to actually associate with increased cardiovascular risk. And but I think physician being a physician, I can only manage things that we can manage, right? So just for example, the example that I've shown you as well as the New York State, by just making a rules not to have trans fat in the cooking actually translate into a better outcome. I'm just not sure how much government can do to actually reduce the air pollution, for example. So I think that one takes a much bigger step, and I think the impact as far as the pollution is concerned may take a longer while to come in. And even if, let's say, since we are neighbors, Thailand and Malaysia, Malaysia can have strict rules just like me and Singapore. Singapore can have strict rules, but Malaysia will definitely pollute Singapore when the wind blows the other way. So, but if I'm Malaysia, I can make a rules about Kuala Lumpur not to have trans fat. I think we can only do what we can do with our capability, but however we will take longer than that or much bigger effort than that might be difficult. But I do agree with you. There are multiple risk factors associated with increase just beyond what I have mentioned. But what I have mentioned in my lecture are essentially things that hopefully can be done and hopefully can be managed by just changing the healthcare policy. Yeah.
I was so surprised that Malaysia is sort of the worst kid on the block. While in the other countries, is there such a big difference between Thailand, Malaysia, Vietnam, Indonesia, because it was really a big difference.
Definitely. I mean, I presume you're asking about the obesity part of things. Yeah. I think we are slightly sort of more developed a bit earlier compared with, let's say, Vietnam and Thailand, but we are a bit slower later, coming in later compared with Singapore. So I think Singapore have realized that and they start making steps to actually reduce all these comorbid. For example, if you walk in the hawker center, they will actually tell you that bowl of noodle will contain how much calorie, for example. While if you walk into a Malaysian hawker, they will ask you, do you want to add more chili oil and all that or not? So it's definitely a different kind of approach. But it's nice in the sense that we realize the problem, so we are making changes. I think this is the same thing in China that we have seen 10, 15 years ago. We have a lot of reports like what you have shown in your last slide. We have a lot of obese kids in China, and China government actually have done something. They make sure they actually select out those who are actually obese in the school. They actually sort of put them in a program. In fact, they actually appear in something like the reality TV celebrities to actually show them how they actually transform all these kids from very, very obese, like what you shown in your last slide, into a much healthier lifestyle. I think it's better to know that you are in trouble rather than you continue to be in trouble.
One thing I was thinking of is maybe in Malaysia you're also more proactive in setting up registries, in evaluating the status of health in your population compared to some of the other countries. So that could be also a reason when you look for something, you find it more than if you sort of ignore it and leave it there.
Yeah, so we found a monster under the bed here,
yes.
in a way.
Yeah. Just to illustrate how successful strategies can be, I'm not sure if you're aware, but in the 1970s, Finland had the worst reputation in Europe in terms of cardiovascular risk. They had the highest mortality, they had the highest impact of risk factors. So the government initiated a national program to focus on improvement of lifestyle. And within a period of 20 years, there was a 75% reduction in cardiovascular problems. 75%. And it shows that there is definitely something you can do, as you illustrated with the trans fat. We saw similar things, for instance, with secondary smoke, where you prohibited the use of cigarettes in a closed space because the people who were not smoking were exposed to the smoke as well, and you saw a dramatic decrease in cardiovascular complications once that was initiated.
I think there is something that we call the paradoxical relationship between modernization and risk. Because actually, all the standard risk factor is okay. But if you take a look at the rich country compared to the poor country, actually the rich country, they have more risk factor. But somehow the cardiovascular mortality and all-cause mortality is less compared to the poorer country. And actually, one indicator is the level of education. So in that case, modernization has some good things and bad things, all right? And in your country, as in Malaysia, if you have to prioritize the risks that you like to change the cost so that you can follow the WHO recommendation, what is the first prioritization that you like to do in your country, Malaysian people?
I think we definitely need more physical activity. If you come to Kuala Lumpur, there's lots and lots of new building, tall building, and that's why I look at Da Nang and I look at Kuala Lumpur. Da Nang, you still actually have a lot of public space that you actually, like in the morning, people can run and all that. And in Kuala Lumpur, I think it's actually very challenging. Unless you're in a bit more affluent areas, then definitely you have good places for you to exercise and all that. But in a lot of middle income or low income environment, they don't have all these facilities. So I think first, coming from the policy point of view, I'm not talking about as a physician point of view.
I got an idea.
Yeah.
By staying in Kuala Lumpur, you should not use the lift anymore, all right? The government just said no lift, just stairs until the 24th floor or something. In that case, people will always be fit in terms of policy from the government. Just
Definitely. But if you have come back from 8 hours office job, I think all I want is just hit in my bed.
Climate is a thing of, as well, you know. Coming from Holland, we always ride our bicycles. First of all, because it's a flat country. And second, because it's not 39 degrees most of the time of the year. So it's easier to be outside to do exercising than in a warm climate. So
we can advocate bicycle in Kuala Lumpur, but then the chance of you dying from accident is higher than cardiovascular disease. Yeah.
And one question for Peter is that you mentioned that LDL cholesterol should be the substrate, primary substrate for having atherosclerosis. But in many of our countries, the people came with acute coronary syndrome with their LDL under 70, about 10 or 12% of them. So, what is your opinion about that? Because there is still other factor beyond LDL that can work.
For sure. I'm not sure if, you know, the measurement of LDL cholesterol in an acute situation does not always reflect the LDL before that acute situation. There is a sharp decline in LDL cholesterol as an acute phase protein during an ACS. So LDL cholesterol is a driving force, but of course, you know, it's not mathematics. There are other factors that play an important role. And in the secondary prevention setting, I think inflammation is really one of the other pivotal risk factors that drives not so much the atherosclerosis, but the complications of atherosclerosis. And I'm really a very strong proponent of using an earlier intervention in patients at a younger age to lower cholesterol and to sort of control the progression of atherosclerosis. But once atherosclerosis is established, yes, lowering LDL cholesterol will reduce some of the burden, has some anti-inflammatory effect, but it's not enough to really reduce that risk. You know, it's not only the LDL in established cardiovascular disease. You have to look at the other risk factors. Inflammation is very important. Renal function is very relevant. Lifestyle factors become even more relevant. And to be honest, I think atherosclerotic cardiovascular disease could actually be eliminated if we really initiate earlier treatment to prevent the establishment and the progression of atherosclerosis. In Holland, we have a national screening program for familial hypercholesterolemia, and we discovered more or less 40,000 patients with this diagnosis. 20% of those are children. 20% are children, so they were diagnosed before the age of 18. They started treatment with cholesterol-lowering drugs from the age of 7 or 8. And we now observe that those children, when they are now reaching an age in their 30s or even 40s, so that was an age when one of their parents had a first cardiovascular event, and they are completely disease-free. The early initiation really allows you to stop atherosclerosis and at the phase where there is hardly anything left or hardly anything there. Well, if you do that in advanced disease, yeah, you can sort of mitigate the plaque. You can see that it's less riskful, but you can't eliminate the plaque. Even in the rabbit that I showed you, there was a changed vascular wall, which is there for the rest of their life. And that is why I feel that in established disease, we have to pull out a lot more strategies to reduce that risk. But if we start early initiation, we can do very simple things in terms of lifestyle and cholesterol lowering, using perhaps statins to reduce that risk.
All right, I think we have half an hour left, so please introduce our audience about what we are going to do in the next 30 minutes.
Navigating roadblocks along the patient journey of cardiovascular pathway. And I think what we will try to do is to look at why we are unable to really address the issues, because they're so evident. They're so clear. We know what is driving it, but for some reason, we are not proactive enough to really act on that. And one of the things I'm very in favor of is using registries, because registry shows you what you're actually doing. There was a very interesting study where they asked physicians, how well do you know guidelines for lipid management? And 95% said, oh yes, we know them very well. And the second question was, how well do you treat patients? How many of your patients are at goal for lipid management? And 90% said, our patients are at goal. But they were able to look at what the physicians did, because there was a registry. And they found out that less than 25% was actually at goal. So there is sort of a different concept that we have, how well we do in terms of reality. And the only way to really establish that is to look at the hard data. Look at how well patients are treated. In some countries, some insurance companies actually dictate, show us, if you have a diabetic patient, how is his HbA1c? How is his lipids? How is his blood pressure? And if they're not on target, you don't get punished, but you get sort of a warning. You know, if 25% of your patients are not at goal, there's something not right. And that is why we need to really establish that, and in a proactive, friendly way, massage physicians to make sure that we do stick and adhere to guidelines.
So I like to start from Professor Shehuk Khan, right? Because we are trying to navigating roadblocks among the patient journey. What is your opinion about that? Dr. Han is a consultant cardiologist from Kuala Lumpur, Malaysia. So what is the usual roadblocks and how can you solve that problem?
I have lots of roadblocks, but I cannot solve it. So we're talking at a physician level. So I'm moving away from the bigger picture. Right. So I think a few things. Mainly I'm talking about resource and also talking about the patient's understanding. So I think most of it will share, so I just go briefly and I'll pass to the next panelist. I think as far as Kuala Lumpur is concerned, I think statin in general are generic. In Kuala Lumpur, acetamide is also generic. So I think most of us actually are able to actually provide and prescribe statin, even high intensity statin plus minus acetamide. The only challenges is we still have a sizable, about 5% of my clinic population where despite the fact that they're on high intensity statin plus acetamide, they're still not able to achieve the target LDL based on their risk profile. And unfortunately, PCSK9 inhibitor and also inclisiran are expensive. We are looking at about 3,000 to 3,500 USD per year kind of expenses, which is definitely not easy. So of course, coming also from the patient's point of view, I think you're going to address it in your next lecture. We still have a lot of challenges about whether the cholesterol is the culprit, and I think they're definitely concerned about the statin. And every patient that we start statin, they will come and ask me, is my liver or kidney damaged already or not by your statin? So I think these are the issue. I'm just not sure whether Philippines has anything different.
All right, Dr. Frederick C. Cheng, right? He is the head diagnostic division, HBC Heart and Vascular Institute from St. Luke Medical Center, Quezon City in Philippines, please.
Yeah, the same thing. No? We do see a lot of challenges, a lot of, I would say, roadblocks And in connection to the first lecture that we heard, no, about how we can address non-communicable diseases, I think we do face like a double jeopardy, because in the Philippines we do see a lot of communicable disease and non-communicable disease. No? On our end, of course, we want to address it from the physician side. We have also from the society side, we do have lipid societies, hypertension societies, and so on and so forth. No? Unfortunately, the obstacles would come from guideline implementation. I agree with Professor Landsberg that if you give an exam, if you do a survey, 9 out of 10 would say, perfect,
Yeah.
perfect. I do give this, I do give high-intensity statin. But in real world, it's not. They only give 10, 20 milligrams of statin. So.
Yeah.
And then guideline implementation versus when a patient comes in, they Google. I mean, of course, when you say Google, the patient will, concerns would be from the safety, always from the safety and not from the efficacy. Second is from the physician inertia. Again, either we're not giving enough therapies, or maybe lack of intensification, or we're not giving. So probably what I also learned from your talk is just go ahead and give high-intensity statins, period.
Let me ask here in the audience, how many of you have seen a rhabdomyolysis in your clinical practice? I've seen one. I see 4 hands. Yeah? So it illustrates, this is the really single most safety issue. I'm not talking on tolerability. The safety issue is rhabdomyolysis. That's 1 in 100,000 patient years. Remember the peanut. You know, if you just remember the peanut and the pill, take that home, and that makes sort of an impact. And the problem is that we don't realize that not giving the right dosage is creating more harm than avoiding side effects. Now, I do acknowledge, you know, there's discussion with patients, there's Dr. Google, there's misconceptions, and it's not easy because patients sometimes simply refuse. But it doesn't take away from the fact that and I will address that in my second talk, that statins are safe, effective, and last but not least, affordable and omnipresent. I sometimes compare statins with Coca-Cola. There isn't a place on this planet where you cannot get Coca-Cola, and there isn't a place on this planet where you not get statins. It's available everywhere. And we tend to sort of shift towards, you know, we have to do something new. There is more advanced treatment. There's better treatments. I'm not sure if they're better. I'm not sure if they're safer. I'm sure they're much more expensive and unaffordable in developing economies. Even in my country, Holland, we're the 15th richest country in the world. We spent roughly 120 to 160 million euros on lipid-lowering medication. If we would switch statin users to PCSK9 antibodies because you want to reach a target below 55, the price tag for that would be $1 billion per year. 1 billion. What can we do with $1 billion? You know, like you said, 3,500 for a PCSK9 antibody to get your LDL cholesterol from 70 to maybe 20 or 30. If you could spend 3,500 on a single patient looking at lifestyle changes, paying for the gym, paying for diet instructions, maybe even giving subsidized healthier food choices, the impact would be far greater at a much more affordable price and a much better long-term solution.
All right, I will pass the panelist to Dr. Tham That Jin. He's the CEO of Frontier Healthcare Group from Singapore, and I heard that the Ministry of Health in Singapore is trying to have some reform in terms of solving the problem of the roadblock for the NCD. I think they should give us some hint about that.
Yeah, sure. I'll just give a summary of what's happening in Singapore currently. I think with regard to the topic of roadblocks, I think the first thing that comes to mind is access to care. Singapore being a small country, our citizens have very easy access to medical care. The problem that we have is actually fragmented care, not so much about access to care. Patients are consulting any doctor that they feel like consulting. They will see a specialist, they will see a GP, they'll see a primary care doctor. And because there isn't any integration, there's a risk of patient being defaulted, patient not being followed up in a proper fashion. And since last year, in Singapore, we have embarked on a population health program. And this population health program is anchored by primary care doctors. And that means that we have enough opportunities to put in preventive care strategies. We can start screening people. We have very easy access to the community. And because it is anchored by the primary care physicians, it also means that we have potentially more touch points. I think I always feel that conversations with patients require a lot of touch points. It's not something that you can do once every 3 months, once every 6 months. So in the primary care sector, we have the advantage whereby when the patients come to us, they can talk about any other thing, but we can always focus on what are the risk factors that they are having at that point in time. Singapore has also been quite strong in patient databasing. Part of the reason is because we are a small country, we're able to collect patient databases. We know where are the high-risk groups. We can potentially even re-stratify the patients. The challenge, of course, is how do we integrate all the databases. This has started to take on something that has become more and more meaningful with the implementation of the National Electronic Health Records in Singapore. And so for the first time in many years, we are now able to see what is happening to our patients in hospitals. By the time they come and see us in primary care, we know what is their latest cholesterol level, we know whether they have done some high-end testing, and then we can apply them in our daily practice. And this aspect, I feel, in the longer run, will allow us to integrate care better. I think at the end of the day, I think one must bear in mind that how much a patient is at risk is not just treatment alone, it's also how the healthcare community, meaning our specialist colleagues as well as our primary care teams in the community, how do we work together as one integrated health team to take care of the patients. There are other aspects that I think we can talk a bit more offline, but I think this is just a brief summary is what is happening in Singapore at this point in time. I understand that for our larger countries, what apply in our country may not necessarily be easy to implement, but at least it gives us some hope that if we know how to do it well, we should be able to improve the care of our patients in the coming years. I just want to add one point with regard to the earlier discussion about westernization, modernization, which Prof. Chi has mentioned. I felt that, in my own opinion, the modernization and westernization is inevitable because many of the countries started off with a huge communicable disease load. And as part of the transformation, sanitation needs to be improved, you need proper housing, and so on and so forth. And that becomes inevitable. And as society improves their standard of living, a lot of the side effects follow through. And now we are dealing with the sequelae and consequence of the side effects.
We have 3 questions from our audience, so I will give each question to our panel, and you can be the comment because Mr. Statin Man, you know everything. So first question goes to our Malaysian colleagues, Professor Chi Kok Han. The question is, can we use statin like atorvastatin 20 milligrams, only 20 milligrams for type 2 diabetes patients without considering the lipid level? Just use atorvastatin 20 for diabetes type 2, whatever LDL cholesterol is.
My approach to lipid management is always begin with the end in mind. My approach is always what is the target for this patient, right? So diabetic, by being a diabetic itself, you're at least medium risk or high risk and above already. And you're usually looking at target as say about 1.8, like that. So depends what is your patient's baseline. If the patient baseline LDL is already, say, 2.4, then your 20 milligram may actually drop to what you want. But if the patient's baseline LDL is actually 3.4 or 3.8, most likely your 20 milligram most likely will not work. So this is how I approach my patient. I want to start with beginning with the end in mind. What is the target? Do I need a high intensity statin or not? High intensity statin, by definition, you drop your baseline LDL 50% or more. But if you actually take one step further, why are you so worried giving high intensity statin or even high intensity statin plus acetamide? I think Prof. Peter Lansberg actually very nicely illustrated what is your normal blood pressure. Your normal blood pressure is 120. What is the blood pressure drop that you're going to worry? I agree. If any patient drop 90 or 80 systolic, you and I are going to be worried. But there's actually no, as far as I'm concerned, there's actually no lowest LDL that is not safe. So why not just go even further? Every drop, every millimole or every milligram drop of LDL has been shown to actually give more benefit. For example, even drop to a 0.5 LDL, for example, patients are still faring better than 1.0. So, to be honest, nowadays I hardly use atorvastatin 20 milligram. My starting point is always 40 milligram and above. If I do not know what's the LDL level, I actually go straight with combination therapy for those who actually for secondary prevention. While waiting for my LDL result to come back. So that's my current approach now, which is totally different from diabetic. You give too high the dose of insulin, patient go hypo. Yes, that's dangerous, but where is the dangerous level for LDL? What is the lowest LDL that you will consider danger? To be honest, none. I have patients in my clinic that walk around with 0.4, 0.5 LDL level. So, to be honest, 20 milligram, forget about it. Yeah. To be honest, I'm on statin. I don't even know my LDL level. I start with 40.
You want to add anything? Yeah. There is actually a strategy where you just give a standard dosage without really looking. It's called the polypill concept. You know, the polypill concept was designed for developing economies, and I think most of them had in mind like India, Pakistan, Bangladesh, where there's a huge incidence of cardiovascular disease at a very early age. I was recently in Pakistan, and they were not surprised if patients came to the CCU at age 20 or 30. It was not an uncommon finding. So one approach they advocated is say, why don't we just give all the adults a combination of statin, 2 blood pressure lowering agents, and aspirin. And the studies that evaluated that showed actually very good results in terms of reducing risk. Now, from the other point of view, they did an evaluation called the fire and forget or aim for the targets. So the fire and forget is you give everybody just the same dosage and you don't bother what the results are. And the aim for the target is that you say, okay, no, I want to make sure that a patient achieves that target, and I will titrate my dosage around that. Now, the problem with fire and forget is the forget. Because patients and sometimes doctors just forget to continue using the medication. Well, if you aim for a target, that both gives the doctor and the patient sort of a responsibility to make sure that you reach that target. So in the long term, that turned out as a superior strategy to really get a better protection for those patients.
I have good news and bad news. Which one do you like to hear first?
Bad news first. Always bad news first.
Good news first is that the good news is we have another 2 questions here for our panel. The bad news is we got only 5 minutes left. All right, so stick to the rule. And my question goes to our cardiologist from Philippines. All right, the question is, when lower the LDL cholesterol with high CV risk people, do you prefer the high intensity statin or moderate statin intensity statin combined with ezetimibe, starting from the beginning? Which is a good choice? for high risk, such as cardiovascular patients?
So these are very high cardiovascular risk patients. So general dictum is no matter how you're going to lower the LDL, as long as you're able to lower down the LDL. Guidelines tell us lower it down to less than 50% and then try to reach the targets. No? While it's true, the guidelines still tell us that we offer high-intensity statin. However, there are some trials now coming in comparing high-intensity statin versus moderate-intensity statin with ezetimibe. I think the name of the trial is RACING. The RACING trial. At least what we, yeah. So what we learned there is both strategies were able to reduce the LDL. Although what we learned there is that in terms of adherence, was better in the moderate plus ezetimibe arm. No? But I think to answer that is no matter how you do it, as long as you reduce it to less than 50%, and at the same time try to achieve the target of less than 55.
So both are correct. Both are correct. It depends.
Yeah. So because before we were thinking about the other pleiotropic effects of statins, exactly. But I don't think we're now in that era of highlighting the pleiotropic effects of statins. What is more important is the level of the LDL and the amount of reduction.
Probably you have different.
Of course.
I see, Mr. Statin Man. All right.
With all due respect, you know, I think it's a very valid strategy, but I'll be a little bit advocate of the devil. I always say, I don't understand. Why do we compare an intermediate dose statin plus ezetimibe versus high dose statin? Why don't we just give high dose statin plus ezetimibe? And the rationale is quite simple. Not only do you get a better LDL lowering effect and you go to a lower level, and as you mentioned before, I'm a firm believer of these pleiotropic effects. And the pleiotropic effects are dose dependent. So if you give a 10 milligram atorvastatin because the patient has an LDL of, say, 72, yeah, you can get this LDL really below 40. But do you have the real benefit of the pleiotropic effects? Because that is also dose dependent, the anti-inflammatory effect, the anticoagulant, the endothelial function. So that's why I'm a firm advocate of using high dose, high intensity. Now you can debate 80 versus 40. What would be the optimal strategy? As a Caucasian, I tend to use 80. I use 80 plus ezetimibe already.
All right, I support both of you, and probably we'll discuss this later in after dinner time. I've got a strong debate. The last question goes to our panelist from Singapore, Dr. Tham That Jin. Please share your insights on the potential risk of new onset diabetes risk when using statin. Do you have to inform your patient all the time that it can cause a new onset diabetes?
Okay, I think that's a valid question. First and foremost, I want to qualify that I'm not an endocrinologist. I'm not a specialist. I'm a family physician in practice. In Singapore, I think you would expect that many of our patients do read up. They do know about the side effects of medications. And there's a spread of the spectrum of knowledge of the patients. And as family physicians, we typically we need to advise patients on risks and side effects of medications that we prescribe. Interestingly, in Singapore, the concept of risk of diabetes with regard to starting statin therapy has not been very prominent, at least from the research studies that we have encountered. As a matter of fact, I think this information is also flowing through into the primary care community. Our primary care physicians are now getting more and more familiar with. There are other side effects that we can talk about, but we typically don't talk about the risk of diabetes when it comes to starting. In fact, the risk-benefit ratio of starting statins, as we have been discussing the last 1 hour, has proven to be very, very substantial. I do want to say that there is still a psychological resistance when you have a conversation with a patient about starting 80 milligrams of atorvastatin, 20 milligrams or 40 milligrams. And that's human nature. The only thing that I say that for us as primary care physicians, I think we want to take a holistic approach. We always feel that time is on our side because, as I said earlier, we don't see patients once in a long while. We can be seeing them today for something about statin and lipids. Next month, we'll be seeing them for cough and cold. And we can revisit the conversation. So actually, in the primary care practice, I've told some of my physicians that it is all right if you can only start with a low dose. We have time to work on higher dosing. But for our cardiologist colleagues and our endocrine colleagues, maybe the stakes are higher. You have to start with a high dose right from the word go, because the next time you see the patient, maybe several months down the road. So differences in practice must be accommodated as we practice in a different kind of scenarios, and the way we structure our conversations with patients will differ accordingly. Yeah.
All right, thank you very much. Actually, yesterday we spent all afternoon discussing about all these roadblocks, and still a lot on our journey, both the physician and the patient. So I think that we are running out of time now. They allow us only 5 minutes of coffee break. Can you make it? Because according to the program here, you got to come back here sharply at 5:35.
Oh my
5:35. So please help yourself to the coffee break and come back here in 5 minutes exactly. Thank you very much.
Thank you so much for our chair and panelists.
It's nice interacting with you.
Yes.
Ladies and gentlemen, now we will have a small survey. Please take a few minutes to do this survey.
No coffee.
Well, you can do the survey like... Now we will have 5 minutes break. Please enjoy the tea break.
Say You know I'm down for whatever tonight. I don't need the finer things in life. No matter where I go, it's a good time. Yeah. And I don't need to sit in VIP. Middle of the floor, that's where I'll be. Don't got a lot, but that's enough for me. Yeah. 'Cause
Gentlemen, to continue our session, I would like to invite to the stage Dr. Hazid Hadi with the topic ASCVD secondary prevention, what's slowing progress. Please, doctor.
Thank you very much, everyone. Thank you for the kind introduction by the chairperson, and also I would like to thank the organizing committee for actually inviting me here to give a talk on the topic of ASCVD secondary prevention, what is slowing down the progress. So I'm from Malaysia. I'm from the National Heart Institute, Malaysia. This is the place which I work. So we do a lot of, we are one of the major centers in Malaysia that provide cardiovascular services. So as a start, I think we'll just go through a bit on the epidemiology of ASCVD. This has been highlighted by the previous speakers, but I'll just go through briefly and share you some of our local data as well. So I think globally, we already know that ASCVD impacts a lot of our people, a lot of the people throughout the world, up to 135 million people, and majority are actually suffering from either ischemic heart disease or strokes. So this is actually the disease burden throughout the world, showing that it has increased over the period of time due to death due to cardiovascular disease, and majority or half of the cardiovascular disease deaths is actually due to ischemic heart disease. And here are the top 3 rankings of the attributable modifiable risk factors, which actually you can't see very clearly, but it's hypertension, dietary intakes, and number 3rd is actually increase in the lipids. So going to our data, the major cause of mortality in 2023, the first is actually due to ischemic heart disease, and this is followed by pneumonia, and the 3rd is actually cerebrovascular disease. And obviously, many places around the world as well, COVID is just, we are still recovering from COVID, but COVID stands at number 4 due to the major cause of death in Malaysia. So the surprising thing here is that patients coming with ACS, if you realize that you can see that majority of patients presenting with ACS, their mean LDL level is not that high, but it's about 3.4, 3.0, 2.7. For non-STEMI is 3.0, STEMI is 3.4, and unstable angina 2.7. Right? And if you look at our Malaysian population over here, 1/3 of our population is having high cholesterol, and 1 out of 2 do not know that they have hypercholesterolemia. And data has been showed by the previous speakers as well, Prof. Chi as well, showing that our population in Malaysia are getting fatter. So from 2011 to 2003, we can see the obesity is getting higher and higher. So in terms of how do we do or the control of our patient in terms of their cholesterol, so this is from our data itself, National Health and Morbidity Survey. 4 out of 10 of our patients do not have their cholesterol level under control despite on treatment. So now, this is good that we have this previous speaker explaining to all of you about the correlationship, but I'll just elaborate further on the LDL association with the ASCVD. So we know that hypercholesterolemia will lead to strokes, heart diseases, renal impairment, and peripheral artery disease. And if you realize in the cardiovascular continuum, dyslipidemia is actually at the earlier part of the cardiovascular continuum. Then combining all these risk factors, patient will develop atherosclerosis, heart attack, heart failure, and eventually end-stage heart disease. In actual fact, most of these diseases, or this heart and as well as the cardiovascular diseases, can be prevented. And showing you that the association based on the primary and secondary prevention, that if you are able to bring down your cholesterol lower, the lower the risk of having a CV events. Okay? And this has been supported by also Mendelian, prospective, as well as randomized control trial, stating 3 important things. Number 1, the lower the LDL, the better for the patient. The greater the absolute reduction, the better for the patient. as well as the longer the LDL is being reduced, the better for the patient. So the ESC has actually classified that elevated LDL is now classified as a causative risk for ASCVD. So based on a systematic review from 300,000 patients from 49 trials showing that with every 1 millimole reduction of LDL, you're able to reduce the risk by 23%. And here, if you're based on a recent trial by the Ferrer trial itself, if you're able to early control your LDL level at 4 weeks itself, you can actually reduce the risk of, you have a fewer CV events with no evidence of plateau. And in fact, the lower the LDL you've got, less than 0.5, the greater the risk reductions. So I'll just show you this randomized trial meta-analysis showing that if you're able to bring down an LDL level of less than 1.8, you get a good CV benefit. But the number of 1 point is very important over here because if you look at various trials, it's shown that with the LDL level less than 1.8, it can actually provide a stalling or the plaque progression or arrest the plaque progressions so much so that it can also actually provide a plaque regression. So these are primary and secondary trial being done looking at plaque volumes, and it's shown that if you're able to get a lower LDL, the percentage of plaque volume also reduces. I'd like to share what Professor Landsberg explained about the cumulative LDL exposures. So over time, okay, you can see that in the normal population, we tend to get exposure to LDL levels, okay? And for patient with familial hypercholesterolemia, you can see the LDL exposure is much higher at an earlier stage. And this will actually cause a significant plaque progression. But for those with polygenic hypercholesterolemia, normal population, we also get exposure in LDL levels. And over time, by age as well, our LDL exposure becomes higher. So now we have the term called the total plaque burden. So you can actually measure the total plaque burden by measuring the LDL levels in milligram, multiplied by the age, you get the total plaque burden. Okay? Now, interestingly also, what you can have here is that with every 1,250 incremental increase in the plaque burden, which is milligram per year, you actually increase the risk by twofolds. Okay? So, just for example, if you have a patient who actually exceeds the threshold of 5,000, with every 1,250, you're actually increasing the risk of MI by 2%. And if you increase it by 7,500, you increase it by 2 times the risk. So if you have a patient whose LDL level exposure is at 3.2 millimole, his risk of developing an MI starts at the age of 50 in average, okay? But if you have a patient who actually having an LDL level of 2.1, at a very early age, the risk of benefit, you can see that the risk of the patient developing risk of MI occurs much later in life. Okay? So you can see how much the risk reduction can be obtained by this patient compared to a patient who has an LDL level 3.2 since an early stage. And also, if you can see for patients with hypercholesterolemia, from an early age, they have an LDL level of 5.2, you can see the risk actually starts much earlier, and the MI risk can actually start at the age of 20 or 30s. So let's go to the guidelines of secondary preventions for ASCVD. So there are many guidelines. I'm just focusing on the few guidelines, which is the AHA. For ASCVD, they divided into not very high risk versus very high risk. So the aim is actually reducing the LDL level of more than 50% for those with they're not very high risk. But for a very high risk, again, you want to achieve a much lower LDL levels. But I like the ESC recommendation here where they specifically mention the target LDL goals. So you can see that for high risk, you want to get their LDL level less than 1.8, but those with ASCVD, very high risk, they considered you want to get their LDL level less than 1.4 and more than 50% reduction from the baseline. But for extremely high risk, you want to get their LDL level to less than 1.0. Extremely high risk are those who are actually having a recurrent events within 2 years. So the Malaysian guidelines also followed what the ESC recommendation for which a patient who are high risk, you want to target your LDL level to less than 1.4 and a reduction more than 50% from the baseline. Very high risk, less than 1.4, and a reduction of 50% from the baseline, as well as extremely high risk, less than 1.0. So, but this is actually released in 2022, suggesting that patients who are actually considered to be of high risk or extremely high risk, a combination therapy should be considered as a basic standard of care. Okay, so for very high risk, you may consider high-intensity statins, may add on ezetimibe. If you're not able to achieve the goals, you actually can consider adding on a PCSK9 targeted therapies. So here's also the recommendation from the ACS for ACS in 2023. So you can see for patients with presented with an ACS, for statin-naive patients, you should consider initiating high-potency, high-dose statin. This is a class 1 indication. For those who are already on moderate or low-intensity statins, you should consider them with a high-potency statins. But those who are actually on the maximum tolerated statins and you're not able to achieve the targeted LDL level, which is less than 1.4, then you may consider adding on the other lipid-lowering therapies, such as ezetimibe or PCSK9 inhibitors. And even with the combination therapies, again, by 4 to 6 weeks follow-up, you're still not able to achieve, then you can add on the PCSK9 inhibitors. So how well is our lipid management is being managed? So in Malaysia itself, from our National Health and Morbidity Survey, a survey being done for 10,000 patients. And you can see that only about, diagnosed without hypercholesterolemia 62, and those with diagnosed hypercholesterolemia is about 40%. And here, you can also appreciate that those who have hypercholesterolemia, out of those, only 40% are actually aware of the diagnosis, and 80% are actually on treatment. And those 80% are on treatment, 40% of the patients actually do not have their cholesterol levels under control. This is from the DICES-2 studies looking at the cholesterol management for patients with ACS and stable heart disease from Asian countries. You can see Vietnam is also included, Indonesia, Singapore, and Philippines. Somehow Malaysia is not in this particular study. But you can see that less than 40% of patients are actually able to get a target LDL level of less than 1.8. So that's that's very difficult for patients to achieve the target LDL levels. And another study which is the Da Vinci study, also looking at patients from European countries. And you can see that less than 40% of the patients are actually able to achieve a target LDL level of less than 1.8. This is based on the guideline in 2016. And in 2019 itself, less than 20% are actually able to achieve a target LDL level of less than 1.4. So in terms of the practice, this is a data from Germany showing that the prescription practice among GPs versus cardiologists, you can see that majority are actually prescribing statins, but combination therapies are much more commonly seen among cardiologists. But in actual fact, from 2023 to 2018 itself, the prescription actually does not change that much. Yeah? So showing that our aim or ability to achieve a target LDL level is still, there's a lot of work need to be done. So in terms of the lipid-lowering therapies, we have a lot of these lipid-lowering therapies. The statin itself, which is the main one that we are discussing. And we have also the ezetimibe, the PCSK9 inhibitors, and we are seeing more and more newer lipid-lowering therapies which will come in the future. But just showing you the first line to treat patients with hypercholesterolemia is still statins, and it's been used for patients who are at risk for CVD, diabetes, and established cardiovascular disease. So these are some of the trials which we've commonly seen again and again for patients with coronary artery disease itself, Miracle, A to Z, PROVIT, and IMPROVIT trial. You can see they usually use high-intensity statins, atorvastatin 80 milligram, and for PROVIT, again, atorvastatin 80 milligram versus pravastatins. Just showing you IMPROVIT study, which of which why ezetimibe is in our guidelines is because of the IMPROVIT study. Patients who are admitted for ACS compared or randomized between statins alone versus combination therapy. Again, risk reduction by 7% at the follow-up. But if you look at the same trial being done in the TNT trial versus the IMPROVIT study, you can see that the LDL reduction based on the IMPROVIT study is actually up to 24% versus TNT. But the CV benefit reduction in the IMPROVIT study is actually much lower compared to the TNT trial, which actually can reduce down to 22% of 80 milligram of atorvastatin, showing that atorvastatin 80 milligram is much more effective in reducing the CV events compared to the combination therapy in the IMPROVIT trial. And nowadays, we're already familiar with the FOURIER trial itself. Patients with established ASCVD put on higher and more or moderate intensity statins, randomized to either PCSK9 inhibitors or placebo. At 3 years follow-up, you can see the reduction by 15% over here, and by 15%. So you can see nowadays people are more prescribing the newer injectables, but again, because of cost issue, this may not be feasible. So in terms of first-line statin treatment itself, we have the high, moderate, low-intensity statins, but you can see the atorvastatin 40 and 80 milligram is able to reduce an LDL reduction of more than 50%. And this is the comparison of different statins. We have simvastatin, atorvastatin, and rosuvastatin. Here you can see that the highest reduction at atorvastatin 80 milligram, you can able to reduce the LDL reduction by 55%. But in terms of time to benefit, atorvastatin has the much more shortest time to benefit in comparison with the other statins as well as the non-statin trials. And here are some of the studies which shown for primary prevention as well as secondary prevention. Primary prevention as well as secondary prevention, you can see that the reduction or the time to benefit can be as fast as 1 month follow-up. So these are the, I think this slide has been shown again and again, showing that the average LDL reduction in various lipid-lowering therapies, high-intensity statins, you have a reduction in average of about 50%. When you add on the PCSK9 inhibitors plus ezetimibe, you get a reduction up to 85%. But I would like to share with you this particular diagram over here. For those with high-intensity statins in comparison with the newer lipid-lowering therapy, PCSK9 inhibitors or the inclisiran, the reduction is almost similar. So if you want to invest something which is cost-efficient and benefit to the patient, I would strongly suggest to use a high-intensity statins because that will be the most cost-effective way in getting the good results. So now we go to the challenges of treating patients with cholesterol-lowering agents. So it's always in the combination between the doctor, the drug, as well as the patient adherence. Okay, but I think this will be addressed by Professor Landsberg in terms of how to overcome in terms of when treating patients with statins. But just showing you that this is a paper published by Kozit Ray and his team, showing that infrequent dosing actually may help to improve long-term LDL control and improving CV outcomes. But bear in mind that these newer injectables are actually can be very costly, and over time patients are not able to comply with this medication and dropped out most of the time. So the most practical at the moment in general population is still the high intensity statins. But there's a concern about having a too much low LDL levels, and we agreed based on the discussion previously itself, showing that there's no flaw to it when you reduce the LDL levels. And this is a study from the FURA trial showing that patients achieving extremely low LDL levels, you do not see any significant side effects between those who are on placebo or those who are treated with the PCSK9 inhibitors on high-intensity statins. But I just share with you this particular meta-analysis from 10 randomized trials, which included about 40,000 patients, very low LDL levels versus 70,000 in the control group. And here you can see that in terms of the adverse events, there's no much differences between the two groups. So you can see very extremely low LDL levels. So currently in the future, we can see that we've got statins, now we've got combination therapies, now over progression of time, we have the monoclonal antibodies, Cernas, and maybe a vaccination in the future or gene editing in the future. But also we are also going to see some newer advancement in terms of the targeted therapies. Previously, it has been always talking about LDL levels, but future we're going to look at non-HDL targeted therapies, and what the new ones is the lipoprotein A targeted therapies, which are going to be coming in the future. With that, thank you for your kind attention.
Thank you very much, Dr. Hafiz. And now I would like to welcome again Professor Peter Landsberg with the topic debunking statin myth, clarifying misconceptions. Please welcome Professor.
Or did I switch it off? No, it's on. Okay, we'll pick up where I left off in my previous talk. The emphasis here will be to convince you about the safety of statins, because I think that is the major barrier, and we'll address some of the critical points that I think have hampered us in using the right dosage of the high-intensity statin. And just to illustrate, this is a query I did in August 1st. There is 340,000 plus articles on cholesterol. There's 110,000 publications on lowering cholesterol, and there's over 60,000 publications on statins. And I can assure you that 99.9% of these publications really underscore the efficacy and safety. And that is what I tried to show you with the first slide in my first presentation with the peanut and the statin. We somehow do not interpret this in the right manner. So there are hurdles, and how to address these hurdles. I think, first of all, we have to discuss Dr. Google and trust, because in terms of managing patients, that is something that we really need. There is a marginal group, medical professionals, that I call the cholesterol critics or the statin skeptics, that do not accept that cholesterol lowering and statins are actually reducing cardiovascular disease. I'll illustrate that as well. And last but not least, realize that the power of pharma industry, and yes, we are here also invited by pharma, but there is a lot of sort of massaging going on by the companies that try to put to market new drugs. And of course, they put a lot of investment in developing these drugs, and they want to see a return of investment. And one really focused group is, of course, the statin users that do not tolerate statins. So you will find a lot of studies underlining why it is important to use low dose plus something else, because that is safer. And although I do agree, there's nothing in life that is only good. Nothing. There's not a single drug without side effects. And although patients expect from us that we come up with a magic pill that they take once in a lifetime that reduces all the risk and makes them beautiful and rich at the same time. Unfortunately, not available yet. So that means we have to be practical and also have to be upfront why and how we do this. This is how doctors were perceived in the past. Half holy, you know, they were really powerful. Patient trusted them, embraced them, they listened to them, and that's only a generation away. I can remember when I was small, the GP was really a semi-god that knew exactly what was right, and my parents and me, we trusted him. Today, we're more like this. We're considered to be sort of second-hand car salesmen. You know, we're not interested in the car, in the patient. We're more interested in making the profits, in making sure that we get something out of it instead of putting something in of it. And that is, of course, not easy to address. It's so easy to say something is not true, but to prove that is wrong is incredibly difficult. Now, this is a paper that was put in the British Journal of Sports Medicine by a academic, Mariana De Masi. I think she was a molecular biologist or she was a biochemist. And she published this article where they really emphasized that statins were useless, dangerous, and that cholesterol is not really a risk factor. And there is a whole group around Mariana De Masi, and there is a few others, that try to emphasize the harms of statin and the harms of lowering cholesterol. This is Dr. Asim Malhotra, also from the UK. He's a sports medicine specialist, also really promoting that we don't need statins and that they're very harmful. And there was even an article in the BMJ, in the British Medical Journal, that had to be withdrawn because some of the premises in this article were actually completely wrong. This is an illustration of what I mean, that we're massaged in using low-intensity statins, more or less giving the feeling that high-intensity statins are bad. As I discussed before, why not give ezetimibe plus a high-intensity statin? There's no articles that compare those. It's always, let's use a low or moderate intensity plus ezetimibe and compare that with a high-intensity statin. And of course, if you give 20 milligrams of atorvastatin plus ezetimibe, yeah, it's a no-brainer. It will be more effective than 80 milligrams of atorvastatin. But if you had given 80 milligrams of atorvastatin plus ezetimibe, that would have been really effective. Let's look at what we can expect in terms of lipid lowering. I think this slide has been presented before, but realize that by using high-intensity statin plus ezetimibe, you can get a 65% reduction of your LDL cholesterol. PCSK9 inhibitors by itself, 55 to 65%. And yes, if you combine these plus the other drugs, you can get up to 85%. And in some patients, that's life-saving. If you have a homozygous or if you have a heterozygous FH patient with an LDL cholesterol of 6 millimole or 240 or 300 milligrams per deciliter, yes, you do need that triple therapy. Let me illustrate based on Dutch data. This is an evaluation that looked at levels of cholesterol in the Netherlands. And then combining it with what you can expect from this treatment. So if your target is less than 100, that means that 99.5% of the population will be able to get to 100 using a cheap statin plus ezetimibe. Only 0.5% will need a triple therapy. If your target is 70 milligrams per deciliter, that means 94%. So the threshold here is 200 milligrams of LDL. And yes, if your target is 55, then your threshold is at 160, which is the 66th percentile. In other words, the majority of the population, and I think probably in Asia, it's even better in terms of less high cholesterol levels, will be able to reach those targets by simply using high-dose, high-intensity statin plus a PCSK9 antibody. Now, what is the average dosage of atorvastatin used in the clinical trials? Who knows? How much? 80. These are the major outcome trials. This is primary prevention, secondary prevention, stroke, renal failure, imaging, and IFAS. I delete pravastatin, simvastatin, and then look here. In the early primary prevention trials, it was 10 milligrams, but here, 80, 80, 80, 80, 80, 80, 40, 80, 80. Patients that participated in the trial came to the office, and the doctor would say, here's your pill, this is what you take, go home, come back. No discussion of it. Is it too high? No. It was the standard dosage, and patients really tolerated that very well. Like I showed you, the Asian subpopulation in those trials were no different from the Caucasian population. What is the most commonly used dosage in 20? In Singapore? 20. In Sri Lanka? 20 milligram. And that's, I've given lectures in South America, in Africa, in Asia, in Southeast Asia. It's always 20 milligram. It's sort of the sweet spot, you know. 10 milligrams may be a little too low, but 40 or 80 is a little bit too high. So let's be safe and let's use 20. Now we're going to discuss the barriers to prevent you from using 80. Can you come up with some of the barriers that you encountered? What are reasons why your colleagues or patients said, no, I don't want to have a high dose? Who can help me? What kind of reasons? CPK, muscle-related side effect. One. What else? Cost. For statins, cost is an issue yeah. See, that's something I feel that is a real barrier that's difficult to address. Although most drugs, statins are generic, in really poor countries, even a low-cost generic drug for a simple person is too much. And that's something that we really cannot address that correctly unless the government accepts that and does something. So cost. What else? Liver damage. I put that on the list. What else? Afraid for non-compliance. Is that a reason why they don't use it? Or is that sort of a consequence of the fear? Yes? But it's something that's definitely, you know, fear of the patient to use something, for sure. Dr. Google. What else? We discussed at the panel diabetes. Yeah? Really a very, very strong argument why they say maybe we shouldn't use high-dose, high-intensity statins. Right? So, these are all my selections of barriers. Now, I don't think I have time to do everything because we only have half an hour, but let's pick out a few that are relevant to you and see how far we can get. I want to go first. I think this is the most important one. Statin safety. Which drug is used by more than 300 million patients worldwide for more than 35 years? True, aspirin. I'll come back to that. Very good. Have we seen different outcomes in terms of safety? I'm not talking about efficacy. Has there been a report? Yeah, there has been one, which is diabetes. It took almost 15 years before we realized that statins could raise your diabetic risk, right? So that means we are aware of people that use statins and reported side effects. Have we seen any other mysterious side effects that were very common? I remember when I was starting with statins, people were afraid for CoQ10. And they said, yes, if you inhibit HMG-CoA, your CoQ10 goes down. That means your mitochondria will have problems, and we'll see a huge increase in heart failure. Did we see that? No. Yeah, we saw increase in heart failure because we were better in treating acute disease, and patients lost viable myocardial cells. So realize that the evidence we have for its safety, I'm not talking tolerability, safety is unprecedented. There is nothing in our whole armamentarium, perhaps aspirin, where we have so much data on safety, right? Now, look, aspirin. How many patients do you need to treat to observe a gastrointestinal bleed or a fatal gastrointestinal bleed? 250 and roughly 2,000. Oral anticonception. How many young women will experience a VTE, venous thromboembolism, because they started with oral anticonception? 1 in 2,000. Do we worry about GI bleeds? Yes, we do. You know, we try to protect patients with medication to protect the stomach. What about rhabdomyolysis? 1 in 100,000, 1 in 1,000,000 patients for a fatal rhabdomyolysis. I rest my case. You know, what else in our armamentarium has this kind of safety profile? And these are the really safety issues. So I think we can kick out safety. Yeah? There are other issues that I will address. 10,000 patients treating for atorvastatin for 5 years will result in 5 muscle-related events. 5. What about safety profile comparing different dosages? This is a meta-analysis of almost 50 trials looking at 10, 80, and placebo. Withdrawals due to treatment-associated adverse event, serious non-fatal adverse events, myalgia, and treatment-related myalgia. Now compare 10 versus 80 versus placebo. I'm sure you can agree with me, there is not a big difference. Sometimes incidence in the placebo was even higher than in the treated group. So this is looking at all the atorvastatin trials. This is looking at simply 80 milligram trials, Prove It, TNT, Ideal, and Sparkle. CK more than 10 times the limit of upper limit of normal. So this is not rhabdomyolysis, this is myositis. 2 patients, total 4 patients over this whole population of almost 20,000 patients. We use evidence-based medicine, right? Evidence-based medicine, this is the pyramid. There is the expert opinion, then there's the case theory, the case reports, the case control studies, the cohort study, the randomized controlled clinical trials, and the meta-analysis. Now, if I claim something about the efficacy, and I say, oh my God, you know, this statin really reduced the incidence of prostate cancer, then the first remark that will follow is say, how did you study that? No, it was an observational registry. Yeah, observational registry. We don't work with observational registries in evidence-based. We need to see randomized controlled clinical trial. However, if I say, listen, I found 10% of the patients in my registry that had side effects, now everybody says, oh my God, 10% of the patients have side effects of high-dose statins. That is really bad. And it's sometimes even higher. It could be 20 or 30%. So now suddenly evidence-based medicine is kicked out. Because if we look at randomized controlled clinical trials, and I will do that when we talk about muscle symptoms, you will see that it is much lower. Let me show you. This is simvastatin 40 milligrams. Simvastatin has a reputation of producing more side effects. This is 40 milligrams versus placebo. Muscle-reported side effects. This is two curves. This is not one curve. This is two curves. Placebo and treatment group, exactly the same. This is looking at many different trials. Again, treatment group versus placebo group, overall 12.7, 12.4%, borderline statistically significant. Interesting study, ASCOT study. ASCOT used atorvastatin 10 milligrams in patients with hypertension. The trial was designed to last 5 years, but it was stopped prematurely because of the benefits observed. I think 2.5 years. And this is what they saw. A 5-year trial, almost 10,000 patients, almost 21% reported adverse events. Now, this trial was actually designed to look at adverse events. And they looked at muscle problems, erectile dysfunction, sleep, and cognitive disturbances. In the blinded phase, muscle adverse events were roughly 0.8% higher. Then what happened? The trial stopped prematurely. So then all the patients in the trial were told, you had rosuvastatin, you had placebo, and now everybody has to have atorvastatin, right? A 40% increase in muscle-related adverse events, simply by the knowledge that now I know I'm not taking a placebo, but I'm taking a statin. Like I said, the evidence we use is from randomized controlled clinical trials. This was presented at ESC and published in The Lancet in 2022. And it's an extensive meta-analysis of all clinical trials using statins. See here, non-randomized studies really fueled misinformation, but the double-blind randomized trials refuted it. It was a huge effort. 38 million records, 840 data sets, 45,000 adverse events, and it took 7 years to do this analysis. Now, this is, the holy grail of evaluating muscle-related side effects with statins. There's nothing else that can improve that. And what they found is this. These are all the different types of muscle-related side effects, from muscle cramps to any muscle pain fatigue, etc. Overall, and this is from almost 8,300 or 8,300 patients, this is a 3% increase in muscle-related side effects in patients using the statins versus the ones using placebo. Now, interesting, in the first year, there was approximately a 7% increase in muscle-related side effects. But after the first year, that dramatically went down. And it was exactly the same in the placebo and in the treatment group. So this is something you can communicate to patients. What I do, I try to use a little bit of reversed psychology. So when a patient comes and says, I have to use a statin, I say, yes, and please tell me if you get a little bit of muscle pain, because if you get muscle pain, then I know the statin works. I know it. I don't even have to measure your cholesterol. I know it works. But don't worry. It's in the beginning, in the first few months, you might experience that, but after a few months, it's gone. So that is a completely different approach, where patients are more aware that they can have some muscle complaints, that it's not serious, but it's actually showing that they work, and that it will disappear after a certain moment of time. There are, of course, people that do have muscle side effects, and you can address that with all the different approaches. So, that about muscle side effects. What shall we do next? Let's go on with the run-in period. Maybe you've heard that in some of the statin trials, and that's something that the cholesterol critics always put forward, they said, yeah, you kicked out all the patients during the run-in phase. Because in the run-in phase, patients that didn't tolerate statins were not allowed to participate in the trial. Of course, you end up with patients that tolerate it, because most of them didn't tolerate, kicked out. Facts. 42 placebo-controlled trials, only three trials had this design. And actually, in those trials, there was not a big difference between those two groups. So again, this is not a real argument to refute the safety of statins. Let's see. Okay, let's go to hepatology. How many of you stopped statins? No, let's put it different. How many of your colleagues stopped statins because transaminases went up? Can I see some hands? Yes. Yes, you are with me. Very common. And to be honest, nowadays, when you have a result, the patient wants to see it. You have to print it out or you have to send it to him, so he takes it home. Then he takes it home, he looks at it, he reads it, ALT, red, dot, goes to Dr. Google, liver. Especially in Asia, liver is like, it's more important than the heart. If you damage the liver, you might as well be dead, right? So then the patient sees, my God, the liver, and so he gets upset, goes to the doctor. What did you do? You tried to poison me? Look at my liver. Many patients stop their statins because of this. Oh. So, this is what we now know from the effect of statins on transaminase elevations. We think that because you inhibit cholesterol synthesis, something changes in the membrane of the liver cell. And it becomes a little bit leaky, and it's easier for those transaminases to get out. It's also something that happens in the beginning and then changes. Realize also that transaminases are poor markers for real liver cell damage. There's a lot of studies showing patients with extensive fibrosis and normal ALT, AST, and vice versa. So it's not a really good marker for liver cell damage. In the guidelines, or in the, I should say different, in the leaflet, in the insert from the statins, there used to be, if your AST, ALT goes up more than 3 times the upper limit of normal, you have to stop it. It's gone. And the NLA and some of the guidelines now dictate, please measure liver function before you start statins. If they are normal, don't measure them again. Because if you measure them again, they're likely to be slightly elevated. That will worry the doctor, but most of all, it will worry the patient. If they're high before you start the statin, you have to find out why. Again, this is from the CTT, looking at transaminase elevations. This is what happened. Patients on statins, transaminases went down. Patients not on statins, transaminases went slightly upwards. So in other words, maybe statins are beneficial for patients with impaired liver function. Which is the most common impaired liver function? NAFLD and NASH, right? Or now it's called MASLD, metabolic liver disease, right? Now, this was a study done in Greece, and it's called the Greece study. So patients were treated with atorvastatin or usual care. Now, the patients who started out with normal liver function and they used a statin, they had a 23% reduction in cardiovascular risk. The patients who started out with abnormal liver functions, they had almost a 70% reduction in cardiovascular risk. Why? Because many of those patients had metabolic liver disease associated with cardiometabolic syndrome or diabetes. And these are patients at very, very high risk. So their risk was more reduced by using a statin. This is looking at a study where they also evaluated liver fat content, the San Francisco study. And what they found at baseline, the prevalence in patients with NAFLD was 100%. After 2 years, after 4 years, there was almost a 70% reduction in steatosis in the patients that used the statin and had NAFLD or NASH. Again, this is an effect of liver enzyme, and a review. Use of statin was not associated with elevated liver enzyme with patients with NAFLD. Significantly lower levels of the ALT, total cholesterol, LDL, were observed when the statin users were compared to the non-statin users. This is a recent study, came out in June, evaluating 8 million patients, and evaluating almost 194 medication to evaluate safety in terms of DILI, drug-induced liver disease. And they had high hopes that statins would be one of those drugs. And what they came out with is that although statins were included in the category of A or B based on reported case reports, severe liver impairment were very, very low, less than 1 per 10,000 patient years. So this is the final proof of the pudding. You know, it shows you that in this huge cohort, there was no indication whatsoever that the use of statins was associated with impaired liver function. How much time do I have? 4 minutes. Then let's go to this one. So the first study that discovered that statins did show an increase in new onset diabetes was the Jupiter trial with rosuvastatin. Jupiter was a study conducted in primary prevention setting in patients with more or less normal cholesterol, but with high levels of CRP. So they had an inflammatory load. And to their surprise, they discovered an increase in the incidence of new onset diabetes. First thought was maybe it was related to rosuvastatin, and then they evaluated all these other studies, and overall there was indeed, in all the statin studies, an increase in the risk of new onset diabetes of approximately 9%. So this is a fact, right? Is that serious concern? Of course, it's not something we're sort of dancing on the tables and saying, yes, we've got this covered. No. But how many of your patients would not get a diuretic or a beta blocker or a corticosteroid? Because they also have slightly elevations of increasing new onset diabetes. You never hear anybody about that. We know that it exists, we take it into account. But with statins, we suddenly get very scared and say, okay, we cannot use them because then we see more diabetes. Now, this is the TNT trial, comparing 80 milligrams versus 10 milligrams of atorvastatin in patients with established cardiovascular disease. And these are risk factors for diabetes. And what you can see here is if you had 0 risk factors compared to if you had 4 risk factors, there was no increase in risk. There was no significant difference between those two. It was clearly established in those with 3 or 4 risk factors for diabetes. This is looking having pre-diabetes in patients using atorva 80 versus 10 milligrams versus patients without pre-diabetes, 80 and 10. Here you can see a difference, about 20% increase in risk. Here it's almost gone, that risk. This is looking at the onset of diabetes in patients with 1 or 2 to 4 risk factors. So if it's 0 to 1, there is no increase. 2 to 4, there's a sharp increase, and overall, you're somewhere around here, 16% increase. On the other hand, this is the impact, what you're trying to establish in terms of cardiovascular event reduction. See, there was almost a 15% event reduction that was more pronounced in the ones who had developed diabetes, because that's, of course, a higher risk. Intriguingly, there seems to be a relationship with statins and slight weight gain as well. So in TNT, the weight gain in the first year was almost 1 kilo. And there was greater weight gain in the new onset diabetes of 1.6 versus 0.9 kilograms in the ones that didn't develop. Those were the ones that actually developed diabetes. So you have to make sure that patients are aware of that and are more compliant, not only with the medication, but trying to improve their lifestyle. And again, the CTT meta-analysis, the holy grail, 150,000 patients, 23 trials, significant increase of new onset diabetes, worsening glycemia, greater effect with high-intensity statins, right? Now let's look at the facts. HbA1c, 0.08% versus 0.24% in the ones using high-dose, high-intensity. Glucose, 1 milligram per deciliter. Lower in non-diabetics, glucose 4 milligram per deciliter, higher in the ones that develop diabetes. So it's not really that patients get diabetes out of the blue. No, they already are prone to develop diabetes. And I think we should be more emphasizing this than saying, oh my God, don't use a statin, you get diabetes. Do statins cause? Yes, but to what extent? These are statin users, these are non-statin users. 9.9% versus 4.4%. So hazard ratio of 2.2. But if you look at the patients that continued the statins and the ones that stopped the statins, there was only a 3% increase. In other words, it is not the statin per se, it's the patient and the underlying disease, which is much more important in that case. Realize also the impact, cardiovascular disease plus diabetes, numbers needed to treat 11, cardiovascular disease, diabetes, and chronic kidney disease, number needed to treat 7 in the patients that used 80 milligrams of atorvastatin. Now, isn't that worthwhile? Isn't that why we do it? And the diabetes is not caused by statin. No, it's caused by the patient. It's caused by the patient, and you give a small push, when you give a statin. And like I said in the beginning, no drug is completely event or adverse event free. So from my perspective, yes, there is a slight risk, as there is with insulin, or as there is with diuretics, as there is with beta blockers, as there is with corticosteroids. But that risk can be mitigated very well if the patient is proactive in realizing that his diabetes is not a kick from the statin, it's the burden of his lifestyle that needs to be improved. So, this looks very obscene, right? It's a matter of perspective. It's a matter of perspective. How do you look at the situation? And you as professionals will have to have the helicopter view to say, the way you look at it is not the right way. And you make the wrong interpretation and conclusion. Improving cardiovascular risk reduction, I think that's the central theme of this whole meeting, remains a really important priority. No drug without side effects. No drug. Not even no food without side effects. No. Fruit is healthy. If you eat too much fruit, not good for developing diabetes. Safety of statins, I don't think there's anything in our whole armamentarium that's comparable. Tolerability of statins needs to be addressed, but that's something that patient-doctor communication, you build the trust, you help to convince the patient, and ultimately, it's the patient choice. Sometimes patients come to me after they have the test results and they ask me, "Are you happy, doctor?" Like they're putting it on me, like it's my responsibility. And I say, I don't give anything. It's your responsibility. If you don't try to reach your targets, do you think I'll sleep less tonight? No, but you should sleep less. Because this is really something that can help you reduce your risk for complications. Don't underestimate the pleiotropic effects of statin. It's something that really are important, especially in secondary prevention. I think in primary prevention, if you start young, it's basically cholesterol lowering. But in secondary prevention, there's a lot of evidence that these pleiotropic effects are even more relevant. I hope that I addressed some of the facts and some of the myths of the barriers of the statin fears. Statins remain the foundation. Despite all these new drugs, very interesting, looks very impressive, but we're still not sure about the safety, and the costs are prohibitive. High-dose, high-intensity statin is like the seat belt in your car. You know, it's safe, very effective, cheap, and it's a no-brainer. You do it automatically. When you go into your car, automatically you put the seatbelt because you know it protects you. That should be the approach with statins, cardiovascular risk protection. Okay, thank you very much.
Thank you so much, Professor. And next, we will have a discussion together on the topic East meets West, challenges and best practice in implementation of Western dyslipidemia guidelines in Eastern settings. Our chair will be Professor Peter Lansberg from the Netherlands, Professor Abhijit Sukhongthasan from Thailand. For the panelists, we will have Associate Professor Nguyễn Ngọc Quang from Vietnam, Dr. Dương Ngọc Long from Vietnam, Dr. Benny Ismail Rusani from Malaysia, Dr. Mubarak Mohamed Raset from Sri Lanka, Dr. Chintan Thong Sripradang from Thailand. Professor and doctors, please come join the stage.
Oh. Yes, this one works.
Thank you very much.
This one works.
So this is a session for East meets West. I just wonder why it should not be a West meets East. Because actually we rely mostly
I'm visiting, so I'm meeting the East, right?
I mean that it always East meets West, because most of the guideline and the information came from the West, almost 100%. I think that in my lifetime, I will chair the panel of West meets East sometime. In that case, it means that the East data became dominated. We're doing more research than in the Western. And also our guideline became widely discussed from the West physicians.
I completely agree. If you look at
That's
the
right.
papers coming out from Asia, they're going
That's
like
right.
a rocket.
That's right. So
Like a
in
rocket.
the next 10 years, if I can live until that time, probably we share the paper from China, from Taiwan, Korea, and many of the Asian Pacific country. I'm looking forward to that. But for today, it is still East meets West, all right? So we are going to discuss about the problem of implementation of the Western dyslipidemia guidelines in Eastern setting. We have 4 hydrologists from Vietnam to Vietnam, and from Malaysia, is that right? And also from Sri Lanka. But we have one endocrinologist, single lady doctors, endocrinologist. So I will introduce her first, all right? Lady first, always. Dr. Chutinthorn Siprapadang. She is from the Division of Endocrinology and Metabolism Department of Medicine, Faculty of Medicine, Ramathibodi Hospital, Mahidol University, Bangkok, Thailand. So please give her an applause. And the rest of our panel, first I will introduce Dr. Dong Ngoc Long. He's Director of Research and Medical Doctor, Vietnam Heart Institute from Vietnam. Second one, Dr. Benny Ismail Rusani, Consultant Cardiologist, National Heart Institute from Kuala Lumpur, Malaysia. The third person, Cardiologist, Associate Professor Nguyen Ngoc Quang, Vice President of Department of Cardiology, Hanoi Medical University, Vice Director and the Head of CCU Vietnam National Heart Institute. And the last but not least is Dr. Muhammad Rashid Mubarak, Consultant cardiologist from Lanka Hospital, Colombo, Sri Lanka. All right, as usual, we start from the lady doctor first. So what do you feel about East meets West? What is the challenge and best practice in implementation, the Western dyslipidemia guideline in Eastern setting, such as in the Thailand situation? Please.
Hello. I think most important between Western and Eastern, because we have different ethnicity, right? Genetics, cause, and lifestyle, and also the diet. And important about the culture is can be challenge for the physician to implement the guideline from the Western to adapt to our countries. Like actually, I have to mention about the CV risk score, because, for example, the risk score from Europe have different in each country, right? Also in Asia, it's a big continent, so I think every country has to have own CV risk score. So in Thailand, we have Thai CV risk score that include different factors that may be different from the America or Europe. So I think it's very important challenge to adapt, to calculate the CV risk calculation for each people in each country.
So usually when we read all the lipid guidelines, they start by telling us how can we evaluate the risk called the risk assessment, the risk calculator. And we mentioned already that we should have our own CV risk score, right? Because the risk is not the same. Actually, in the Asian population, we have more death from the stroke than the coronary artery disease. And somehow for the lipid treatment, actually it can reduce the CAD death more than stroke. Even that we can see some data that when we treat the right patient, sometimes the stroke can come down also. So I will challenge panelists with this risk assessment tools, because in Thailand we got the Thai CV risk score. Actually, it's not complete. It's only a certain age group that we can evaluate the risk. So how about in Sri Lanka? You have your own risk score in terms of evaluating the risk for primary prevention?
Yeah, we have, actually we follow the guidelines from the West because we don't have enough data, studies. We usually follow the European guidelines, the ESC guidelines, and the calculation charts are available. And the WHO chart is commonly used. WHO, the Southeast Asian region B category, where Indonesia, Sri Lanka falls into that category. We can use that chart for the risk calculation, and we follow the guidelines, recommendation targets given in our health ministry recommendations. Almost the same numbers, the very high risk 55, 70, and 100. Those numbers are we follow it, but we have a real problem in these numbers. Because when you take this east, west, east, if you take the whole east, the Sri Lanka, India, Bangladesh belongs to a different category. It's Southeast Asia. So that the lipid is called atherogenic dyslipidemia. We see a different lipid profile in most of our patients. Our LDL cholesterol is not very high, extremely high, what you expect in the other regions. It may be less than 130, 100 to 130, maybe that may be the general trend, where you consider it as almost normal or mildly elevated. But we have another problem with that. That is we have high triglycerides. Triglycerides are high. So when you take these patients, it will be 180, 200, 220 in that range, associated with a low HDL. And that when you follow these guidelines, we actually undertreat these patients. So we may have to go still further in bringing down these numbers. So even the 70, 55 may not be enough for our patients, because when you take these patients in the secondary prevention after a heart attack or a stenting, we don't see a very high LDL in these patients. We see about 110. So sometimes we tend to don't treat these patients with aggressive management. So we may have to go lower. So that's why the Indian guidelines, the Lipid Association of India, they have gone to a very low levels of 50 milligrams and less than 30 milligram in a very high, extremely high risk patients, those numbers. And we see to overcome this, because of the high triglycerides and the low HDL, our population might be having another problem with that, the LP-Lp(a) may be high. So that's the South Asians tend to have one of the highest. The lowest is the Chinese, and when then comes to our one may be higher. So other thing to consider this LP(a), we may have to consider ApoB as a marker that will give the exact picture of a non-HDL type of treatment. That's what we face in our challenge.
Thank you very much. And we have two competitors here. For the Vietnamese, I think that some of our speakers like this morning show that they are still very slim compared to the Malaysian. Because Malaysian is, I think that they're one of the most obese populated nation in Southeast Asia, number one, right? And Thailand maybe second. All right, but somehow we got to consider differently among the Malaysian treatment, Malaysian guideline, and also the Vietnamese guideline. So you should focus on different part of population, right? So what is your opinion about that?
So basically, we discussing today is how about the implementation of the guideline, especially for primary prevention. I think I totally agree with the previous discussion saying that the importance of ethnics issue also important for us and also for the culture. I think the first point we should emphasize that it totally depends on the individual perception. And when we're talking about the primary prevention, usually the patient don't see the side, the event. So they usually talking to the patient, to the doctor, say that why I totally healthy, nothing happened. Why I need to take the drug? It's very costly. It's side effect. Of course, side effect is on the paper. It's not real, but they impact a lot. And also in the traditional culture, when you take the drug, it means that it's not well. So this is something like we need to give a lot of talk and discussion with the patient and with the population, changing the concept about taking the drug for primary prevention. Second point is very important, because the population, the patient don't see the effect of the drug. For example, like if you take the antihypertensive drug, you already measure the blood pressure every day, you see how the drug impact on your blood pressure. And then patient usually take the follow-up the treatment quite well. But for the LDL cholesterol is another story because you need to take a blood test, quite costly. And sometimes you cannot do in the primary care setting. So that's why you need to move a little bit further for example, like you go to the provincial hospital to take the blood test. It's very costly and not convenient for the patient. So how to follow up, how to know that drug is effective? When another hand, you heard a lot and you think a lot about the side effects. So this is something like not easy when you implement the guideline in reality. The third point is, I think in Vietnam is a little bit different because in our population, we not only facing the CVD, but also facing the chronic inflammation. So chronic inflammation is another story because inflammation can easily to trigger the event. And even the LDL is not high, but the event is high. So this is another story. And in this situation, we think that we need to emphasize the anti-inflammation of the statin because this is really important for our population. And the fourth point is I totally agree with the speaker from the Sri Lanka because in this area, the triglyceride is quite high. And usually when the patient see this result, they usually asking, why I take the statin because it is not indicated for the high triglyceride. So this is another story, right? So that's why we need to give a lot of information, convene the doctor in the community to give the drug, to start with the statin. So I think this is a 4 point is much more important compared to the other thing like logistic when you don't have enough drug or something like that. But it's not as important as the fourth point we mentioned. Thank you.
Is it the same in Malaysia?
Well, pretty much the same because we're talking about Malaysia being part of the the same region with Vietnam, Thailand, Indonesia. So I suppose that all the challenges that are faced within the same region also present in Malaysia. However, I think in Malaysia, as you can see in the slide just now, that shows we have the highest BMI. Obesity and weight is about 50%. And if you look down further line of other risk factors like hypertension, we got like 30% prevalence, cholesterolemia 40%, diabetes 20%. So all of this, in the end, contribute to the overall, high risk of ASCVD. However, I would like also to point it out with regards to the first point just now with the Western guidelines. We also have identified, if you look at the ACC American guidelines, they have this fine print to say that the calculator that they use tend to underestimate the risk of ASCVD in the South Asian population, Sri Lanka and India, and tend to overestimate the prevalence of ASCVD among East Asian. So in Malaysia, we did a 2 local study. we also found the same thing, that the the ACC PCE tend to overestimate the prevalence in Malaysia. So what we did is we had looked at the data, and we found that for a multi-ethnic population, like in Malaysia, like we have in majority Malays, but we also have Chinese and Indians, we found that we better suited with the old Framingham risk score calculation tends to be a better discriminator for the CVD risk compared to the modern PCE equations. But however, not to forget the European score guidelines, we tend to marry the two with each other. That means we re-stratify them using the American guidelines, the FRS, but in terms of treating to targets, we follow the Europeans one. So we have, I think, the best of both worlds.
All right, I'd like to ask Mr. Statement. Because we got some problem here from, we know that the endocrinologists, they may encounter the patient who have high triglyceride, all right? In Sri Lanka, also high triglyceride, probably LDL cholesterol, it doesn't matter much. Also in Vietnam also, even in Thailand, you know, when we do the cohort study, the things that mostly predicted future SCVD is low HDL, not the LDL cholesterol. Got any idea about this? Should we use the LDL guideline as in your country?
I have my own microphone. So, first of all, statins do lower triglycerides. You know, if you use high-dose, high-intensity statins, 40 to 50% lower triglycerides. So don't underestimate the power of statins to do that. Second thing is that high triglyceride, low HDL is something that's frequently associated with pre-diabetes metabolic syndrome. So that's a separate category of patients where insulin resistance plays a very important role. Now, addressing the insulin resistance, I find that's very, very intriguing because there is such a difference between South and maybe Southeast Asians and Caucasians in the incidence of insulin resistance and metabolic syndrome. Of course, you know, obesity, diet plays an important role, but apart from that, there is really something that we still quite not understand, why the prevalence and incidence of insulin resistance is so high in Asian, South Asian populations. Now, before I go on, I have also one question that I was thinking of. If we look at potential reasons why things are different in Asia compared to Caucasian, one thing that always pops into my mind is a different interpretation of BMI. You know, in our country, BMI below 25 is considered okay. But in Asians, BMI has to be below 23. And that is based on quite some convincing epidemiological studies that even with those BMIs, the risk is quite high. One question I have also for the cardiologist is there a difference in the anatomy of the coronary arteries in terms of size, in terms of vulnerability, that makes Asians and South Asians more prone to develop cardiovascular disease as well? And the second point that I think is also quite relevant and has not been addressed quite extensively is air pollution. If you look at large cities in Asia, South Asia, air pollution is really a very pivotal risk factor. And again, inflammation plays an important role in that as well. So I think those are things that we have to sort of digest and find out. And registries are pivotal. If we have good clinical registries where we have extensive clinical data, I'm thinking about Taiwan, I'm thinking about Korea with their very impressive registries, we can use that and then implement our newest metabolomics, proteomics, imagomics to find out what makes now a big difference and what makes an impact. In general, I think risk factors are risk factors. Hypertension in Asians, Caucasians are the same. High cholesterol in Asians, Caucasians are the same. But we do know that the impact of risk is different, for instance, in males versus females. We're now starting to dig out what's the difference in terms of pregnancy outcomes and long-term cardiovascular risk. And look and behold, we're finding out that if you have, during pregnancy, complications, you are at very high risk of developing cardiovascular disease after menopause. So I think these kind of strategies to filter out what are relevant clinical differences and what do they mean in terms of management, therapeutic approaches are going to be very, very relevant. And like I said before, Asia is steaming ahead, you know, in terms of medical science in China, Taiwan, Korea, Singapore, Thailand, Malaysia. You know, you started later, but you're really catching up quite quickly. And I think you have the advantage that you're much more adaptable than we are. You know, Europeans are somewhat sort of, we think we know it all, we think we have invented everything, and that we should be in the forefront. It's finished. You know, Europe and US are going down the drain, and Asia is rising, so you have a responsibility in that sense as well towards your own population and also towards the whole global population.
Thank you very much for your sweet comment. Anyway, we mentioned a little bit about BMI in Asian population. I think that Dr. Jutinthorn can answer that because we have different standards, right?
Because in Asia we have a lower BMI cut point, like 23 is obese, already overweight, and 25 is obesity. It's more different with the European that use healthy, right? I think the problem because in Asia we look not so fat, but we have very more visceral fat, right? So I think it's we underestimate that, and we have I think the marker that we have high triglyceride, that means that we have insulin resistant. I think today we talk a lot about statin, but I think for my point of view that I working like diabetologist, that we have a GLP-1, maybe interesting option that we can work together with statin to reduce the atherosclerosis.
Yeah, I think there's a lot of promise in these new GLP-1 receptor agonists and SGLT2 inhibitors. I think that we're now at the beginning, and we see so many interesting papers about the impact of these drugs in disease. Absolutely, yeah.
Still a long way to go, you know, because every, even clinical trial support using it, it have to wait for another 12 years at least before it became like a widely applicable to most of the people. So it's still in the textbook.
Yeah, there's one thing that I think is also quite distinctly different between Asia and Europe, and that's your preference for natural medicine, for herbal medicine. And that could be quite challenging as well, because some of these herbal medicines are not as safe, although they're embraced by some of the patients. You know, the red yeast rice as an alternative to statin. Yeah, on the one hand, it is also a statin, but it's less the quality of that is not as high. And we've seen reports also on rhabdomyolysis with these kind of drugs. So is that something that you encounter in clinical practice also? Patients wanting to take like herbal medicine and steering away from classical medicine?
I think people love herbal medicine more than our medications. They love a lot, but I think to compromise that, I think to tell the patient that they can use together, but I mean under our supervision, right?
Yes.
So I think it's hard to compete because they also have like a doctor that's like pro on anti-aging, wellness, a lot that look like healthier than our medication. So I think we have to compromise the strategy to talk with, educate with the patients that we have to use they can maybe use together, but
How about
must
the
tell the
same,
doctor.
the same as in Vietnam? Because a lot of herbal medicine too.
I think so, and also not only the traditional herb, but also the traditional exercise, especially in India, in China, also in Vietnam. So another point, another thing is really important here, because this morning we discussed about the gut microbiome, right?
Microbiome, yes.
Yeah, microbiome. So it affected the effectiveness of starting based on that. And if you think a little bit about the herb and the traditional exercise, actually the herb and traditional exercise, for example, like yoga, qigong, tai chi, can change a lot the gut microbiome. So it is another way to go, because it is in reality, it's a lot of patients already take the herb and traditional way, and it can change the impact of the LDL cholesterol. So this is another way to look back, and if you can combine the most important point from the West and the East, can be effect and benefit for our population.
But I think we're still far away from having the evidence-based data so that we can support our guideline, all right? You'd like to write some guideline about herbal medicine in lipidology treatment, and then you can have the West meet East.
Yes.
But you've got to wait for another maybe 10 years before we get the data about that. So I'd like to come back to East meets West again. And in Thailand, do we need the lipid guideline has just came out, right, from the Royal College of Physicians. Do they make any adaptation from the Western guideline, or is it still the same, more or less the same?
I look at the guideline, but it's quite similar with the European guideline. But I think more important about the cost of medication is almost the important issue as well. I think every country.
So they are very careful when telling us how to use SGLT2 inhibitor or GLP-1 agonist or something like PCSK9 incretin. You got to discuss about this a lot because of cost constraint, right?
Yeah, because they have a study about cost effective, but it will cost effective when the price of the medication is lower. So it's very important that we have to make a guideline, like to put the space that the doctor may have decision under limited resources.
That's right, because for the Thai government, they have put a ceiling to the one query that can be saved, all right? For one query, they like to pay this amount, certain amount of money. It's not the same as in the US or in your country because the query is quite low. So with the new medication that we can use to save our patient, it's not cost effective at all until we get some generic brand.
Yeah.
Is it the same? Do you like to modify your guideline a little bit?
Yeah, as I said earlier, our guidelines generally follow the European targets, and that's how we follow. And when it comes to treatment, most of the population goes to the government sector, more than 80%, 80-90%. And usually the atorvastatin is available. It's issued free of charge. Health is free. Yeah. Even stenting is done free. CABG all done free, most of the population. So the drugs are available, atorvastatin, available in a free charge generics. And when it comes to another 10-20% population where they resort to the private sector, the many brands are available, mostly coming from India. Government has put a strict restriction on price targets. There is an upper limit for the price. For example, 10 milligram atorvastatin, this is the price, 20 this much, they can't go above that price. So whatever drug coming into the country is sold at that price. So there are generics, there are branded generics, as well as the original, the Lipitor. Even all come at the same price. Yeah. So that's an advantage that we get the original innovator brand for the same price as the other drug. So that's a great advantage we have in treating patients with dyslipidemia in the private sector.
I think that in Malaysia, the economy is growing quite fast, becoming the rich country, rich and richer, and of course you may have no limitation, right?
Well, where practice is slightly different from the rest of the Malaysia, because in the National Heart Institute, we are actually a private hospital, belong to the government. So again, we have a little bit more access to various medication. I mean, the injectables, Repanta, Cybrava. But of course, we also have generics that we can, give to patients. So we'll see. I think at the end of the day, it depends on the type of patient that sits in front of you. Every patient is different. They all have different risk factors. And if we think that we could achieve the best, efficacious target treatment, we will start with the most, in terms of the least expensive medication. But if, let's say, the patient is, very high risk, these second events that come within, 2 years, we need to be a bit more aggressive, that we can, start to give a bit more aggressive medications. Yeah.
I think that is very reasonable for among our countries, because we got to take a look at those who have a very highest risk. In that case, I think that aggressive treatment, even if the quite expensive medication, is very cost-effective to prevent the future events that is coming in. And actually, we need to negotiate with the taxpayer also. About in Vietnam, what do you think about this? The accessible to new medication that may be expensive for those who are very high risk.
Yeah, especially new medication is expensive. Vietnam. I think not only Vietnam, in Thailand, Philippines, Sri Lanka, the same. In Vietnam, we have a lot of kind of generic statin. And we also use Europe guideline. And I hope we have many pilots model to collect the data set. I hope the data set will help our to validate the European guideline, maybe a guideline of many other guidelines. At that time, we have better guideline for Vietnam. We will focus on how to simplify the guideline, national guideline, and in order to educate for health system in all doctor in grassroots, especially in the district level, in community level. DC, they know they can practice clinics, and I hope we can collect many data, and then after that we share the resources for you, for all of you, the near future.
I just want to ask Professor Landsberg. So because basically in the guideline now we have a lot of cut-off. So and when we implement this guideline, in reality, the doctor in primary care setting is very difficult for them to follow. So for example, like if they ask you to choose only 2 cut-off, so what is your selection?
Yes. So there was a very interesting review article in the European Heart Journal, more or less presenting that the guidelines that are constructed in Europe and the US are not realistic for developing economies. And it sort of creates a backlash, because then primary care doctors say, what, 55? Forget it, and they get inertia, they don't do nothing anymore. So we have to be more realistic, and I like the term sweet spot, We don't need to go all the way to the bottom, but find the optimal way to reduce risk at an affordable price. And although, when drugs first were developed, we looked at efficacy. And if they were effective, we said, yes, let's use it. And then we realized there are side effects. Okay, they have to be effective, they have to be safe. And then we found out, yeah, but sometimes they're very expensive. Then they have to be cost effective. So we had QALYs. And now I think we're getting to a next stage. Can we afford it? A drug can be cost effective, but if it's a disease that's omnipresent, even a cost effective drug is unaffordable. So we have to come up with new strategies. And to give an example, PCSK9 antibodies, I'm maybe a little bit negative about PCSK9 antibodies. I think they're very great drugs, but they're expensive. So how about in an acute setting, we use PCSK9 antibodies for a year and then continue with using standard treatment, because we can rapidly reduce cholesterol in an acute setting, which I think is beneficial, but we can keep it at levels below 70 and make sure there's no progression of atherosclerosis. To be honest, I'm more a proponent of using a target below 70 than below 55. Yes, there is additional benefit going below 55, but if you look at, for instance, the Improve It study, where they used ezetimibe plus simvastatin versus simvastatin only, the absolute benefit in that group was 0.4%. 0.4. Now, ezetimibe is an affordable drug, but if you look at the outcome studies with PCSK9 antibodies, yes, there was a slightly lower risk, but the curve doesn't go like this. The curve goes like this. Yeah. So finding that sweet spot, and I think below 70, 50 to 70 is a sweet spot. Maybe in some very high-risk patients you could lower, but I would be more in favor in addressing inflammation, blood pressure, other drugs for metabolic problems than getting to a lower level of an LDL of 20, because that's not going to solve the problems. One other thing I would like to present to you, which I found also intriguing in terms of an Asian population, it's epigenetics. We found out in Holland that in the Second World War, in Amsterdam, there was a famine. And the individuals that were exposed to this famine were followed. And also their offspring was followed. And what they found out is that the offspring had a much higher risk of developing cardiometabolic disease. And I think that is something to take into account in Asian and South Asian populations. You know, famines were sort of common practice in this region compared to Europe, where it was 100 or 150 years earlier. And what's even more intriguing, if you have a female fetus, the eggs of the female fetus that are being developed during that period have consequence for the female offspring of that fetus. So you have sort of a second generation that is still going to have some epigenetic factors that could explain some of the risk that we see in Asian and South Asian population.
We have only 10 minutes left, but anyway, we have two questions here from our audience. The first one will go to the cardiologist. 4 of you, right? You have to answer it short, all right, because we got only 10 minutes left. The question is, with patients who has undergone coronary stenting and is currently stable, has reached LDL-C level by using atorvastatin 80, so stable case after stenting using atorvastatin 80, could we reduce the dose to 40 milligrams to save cost starting from Malaysian?
I mean, if cost not an issue, that would have continued on the 80 milligrams. There's no reason to change your Olympic team when you're winning. But if cost really an issue, I think it's come down to, in the end, you know, the discussion between you and the patient. I think there's always a common ground where we can reach. I mean, it's not about our what we want, but also what the patient, you know, wants to as well. So I think in the end, it's just doctor-patient relationship discussion, addressing concerns. What do they have in mind? If there's a better option, I mean, we can always give a higher dose.
So stay on 80.
Yeah, I mean, with the generics, no problems. But yeah, but of course, you know, we need to understand what the patient's real concern is.
Yeah, whether it is generics or the original, we'll have to continue the statins. So that's a great challenge we have in our peripheries. We treat these patients and put on high statins, and they go back to their GPs or the primary physician, and they see a lower level of statin, the low level of lipids, and they tend to reduce the dose. So that is the great issue we have. So we have to emphasize the fact that they should continue to take it if they don't want to get another issue, another event, cardiovascular event in the future. So we should continue the same dose.
Same high intensity. Is this the same for both of you? Continue high intensity. And how about not the cause, but the patient complaint? What is your solution? It's 80 and already I got your target when you mentioned, and I like to reduce it down because I got muscle pain sometimes, I got cramp.
I have my own mic. You know, one thing I've learned over the years, that it is the patient's responsibility. You know, I always say to patients, you are now trying to climb Mount Everest. And to be successful in climbing Mount Everest, you have to prepare yourself. You have to make sure that you train, that you have the proper diet, you have the special equipment like oxygen so that you can survive the journey. But it's a beautiful journey. You can have a lot of adventures. That's the same with cardiovascular disease prevention. I'm your Sherpa. I'm your guide. I can explain the road to you and I can come with you, but it's your trip. It's not my trip. And if you don't want to do it, your responsibility. I can explain things to you, I can do things for you, but it's your responsibility. I think we have to put more emphasis, because patients like to throw it over the fence and say, you know, you solve the problem and give me something like the magic pill once in a lifetime, beautiful, rich, and healthy. Not yet. One thing I remember from Malaysia, he has disease, but was Dr. Koka Lin. He was a famous cardiologist from Malaysia, and he was very active in treatment of FH, homozygous FH. He managed to get funding from banks and airline companies to sponsor the FH patients for apheresis, which is 60,000 euros per year, and Malaysia Airlines gave the tickets for the patients to travel. The patient didn't do. They were not, you know, they said, yeah, I'm missing a day's work, you know, there's all these reasons why they didn't want to do it. And it showed me that you have to make sure that the patients understand, take on the responsibility, but it is their responsibility.
All right, good solution.
Yes.
Good solution, but it takes some time.
Yes.
Yes, I think that during the talk, Professor Landsberg already did explain about the burden of like that we have a cutoff to the 9 grams. So it is very important and easy to explain to the patient.
Yes.
Because when you consider the burden of the plaque is something like you explain to the patient to keep the treatment for a long time. However, another question appears. You prefer to using the high dose of the statin, or you prefer to reduce the dose statin plus ezetimibe?
I prefer to use high dose plus ezetimibe. Yes.
Yeah. It's okay, it's okay. The lower the better. All right, all right, all right. Even it's not evidence-based, you know. All right, so good news is that we have 2 questions left. Bad news is we have only 4 minutes. So let's start with this one. It's very interesting. There's a common perception that the dose of statin in Southeast Asia population should be a little bit lower compared to the Caucasian population. Is that right in Vietnam, yes or no?
Yes. Yes, it is a very common perception. And especially for the older generation. I'm doctor, sorry for that. But it is true.
Your generation, right?
Young generation a little bit more aggressive. Yeah, and because we see the impact, we see the results. So that's why we believe on the high dose of the statin.
All right, all right. The same opinion? All right. Yes or no?
Yes, perception is there, but we see a good response to 40 milligram compared to the Caucasians. Most of them reach the target, and very less time we use the 80 milligram.
The same, yes, right? Because in the Thai ACS registry, we use only, not reaching the high intensity dose. The average is only 30 milligrams of atorvastatin, still not reaching the high intensity. So in that case, we are still share the same common perception among Asian physicians. I don't know, because the size, because of the side effect, or how can we overcome that? It is just a reflex, no, not come from the brain. Sorry.
No, I mean, the way to change attitudes, because that's what physicians is not easy. For everybody, not only physicians, it's different to change attitudes. How do we change attitudes? By gaining trust. If you gain trust and people believe what you say, and there's different strategies you can use to do that by organizing meetings. Like one of the things we did in our hospital is we organized patient educational settings for diabetics, where we had 50 diabetic patients, we had a surgeon, we had an endocrinologist, we had an internist, we had a diabetic nurse, giving them all the perspectives. Because for them, it was like so confusing. You come in with no symptoms, and you leave the outpatient clinic with a big bag of drugs for your hypertension, for your lipids, for your diabetes, for your stomach protection, etc. So by explaining what is happening in the body and what the consequences are, people start to understand. Now, this is not easy, and it is time-consuming, and I think that is also a big issue in Asia. I know, for instance, in Indonesia, it's not uncommon for a cardiologist to see 100 patients in a morning session. 100 patients, you know, what can you do if you have 2 minutes per patient to explain things? You don't. And these are things that are really relevant if you want to change attitude. And of course, there has to be support from the government to explain things. You know, we were very successful in stopping smoking. We're now seeing a trend towards better exercise, better diet, sugar tax to change people's attitude. It takes time, but we have to do it. We always say, think big, start small, act now. You know, that is the strategy if you really want to be a change. It's 1,000 steps to here, but you have to make one step, and one step at a time. In the end, you will reach the 1,000 steps.
We have only less than 1 minute left, and so we got one question here. So the last question goes to Dr. Yutinthorn. What is the safety of high-dose statins in elderly patients or in patients who have a chronic hepatitis?
I'm not concerned about the elderly patients because the one thing we have to look at the renal functions, right? I mean to look at the safety of the dose of statin, but not only for the age. I think have to.
But actually, all the guidelines mention that we should be concerned about the age of the patient because they not belong to many mega trials. So beyond 70, sometimes they suggest using it as a 2B. It means that you can use it after consideration, but it is not a must. It's not the 1 or 2A.
Yeah, because from the clinical trial, it's limited participants only less than 75. But I think we have a lot of people entering at the age more than 75. I mean, the patient have statin at lower that age and have more age and enter to the 25. I think that people should. I mean, from my opinion, I think the elderly patients have higher risk of severe risk that we have to focus, but we have limited data to influence the guideline.
One final word from Mr. Statin.
Yes, okay.
Will they change the suggestion in the future from 2B to something like 2A for those who are beyond 70?
Well, there are 2 big trials going on in elderly patients.
Right, but we don't know the results.
So the results are still waiting. We have good observational data in primary prevention setting that statins seem to protect even in the very elderly.
Observational data.
Observational is you know, it's giving you a slight impetus, but it's not the hard evidence. And you have to use proper clinical judgment. You know, if it's a frail elderly patient who has a lot of comorbidities, it doesn't make sense to pester him with another drug, and you have to make sure that you don't use the highest dosage if this is a small elderly lady with a BMI of 15. On the other hand, secondary prevention, for sure. Also in elderly patients, it will help because of LDL lowering, but also these pleiotropic effects. And then the trials, hopefully there's 2 trials coming out, I think next year, that will give us the real evidence.
It can change the guideline a little bit.
Yes.
But
yes.
probably maybe class 3 recommendation, never use it. For the hepatitis, I will leave it here because actually we are overuse our time. Like to stop it at the right time. And actually, Landsberg is still here until tomorrow.
Yes.
Anybody got any question, you can ask him because he is the certified statin lover. So it is very nice having all of us here on the stage, and also I would like to thank you very much for coming for a long way.
Thank you.
And I'd like to thank all the audience because we got many interesting questions. I hope that it does not come from Beatrice, it should come from you. Okay, thank you very much. Have a
Thank
nice
you.
day. We have to move to the other room, right?
We stay here
that
or
right?
we move? We stay here.
Stay here?
And they come. Okay. Thank you. Oh, interesting.
Thank you so much, our chairman and panelists. Ladies and gentlemen, thank you again for your participation for this afternoon session. Let's take a short break, and after 15 minutes, please gather in this room for today's final presentation. Thank you.